Hello, sir.
Hi, I thought I'll just try sharing the screen and see whether it is working. Otherwise, I'll send the presentations to you also.
No, right now we are sharing the screen. That's why maybe you're not able to focus. You can send the slides, sir. We can have it as a backup. In case.
I'll send the slides.
Yeah, okay. Good afternoon, sir. Mattu, sir, welcome. Mattu, sir, can you hear us? Oh. Dilesh, can you hear us?
Yeah, I can hear you. Can you hear me?
Yes, you are audible.
Thank you.
Hi, everyone.
Hello, ma'am.
Hi, ma'am.
Swati, Dr. Mattu is here, but are the other panelists around?
Sir, Dr. Shibu is joining. Yeah,
And
so.
Shibu is going to be the chair for the first session?
Yes. So
joining.
once he also joins, and once it is 2 o'clock.
Yeah, we too have 2 minutes. We do have 2 minutes. Can wait.
Mattu sir, hope we are audible to you.
Yes, you are audible. Am I audible?
Yes, sir.
Namaste, Dr. Mattu. Namaskar.
Namaskar, sir. Namaskar. How are you?
Best, thank you very much for this time. I know आप लोग तो वहाँ पे बहुत ही busy रहते हैं, लेकिन बोला this is something very interesting. We had very good time yesterday also. Very nice presentations, good discussion. I'm sure we are going to enjoy today's sessions also. Great.
It's a great initiative done by the team, and congratulations for this.
Yeah. And what happens is the health system perspective, especially NTP, how it overcomes the challenges of pediatric TB is so important. I'm sure people are going to enjoy that. And many of these people were from the private sector and the research sector. So they knew about what research is happening, but people hardly know about what happens in the health system. So Pehla session is going to be great. People are going to look forward to your session. That will be great.
Definitely.
So we have some pediatricians also. Dr. Anand is there. Anand, good evening. Good afternoon, rather.
Good afternoon, sir. Good afternoon.
So I'm sure this is going to be a very good, interesting session for you. You will know the NTEP perspective. As a pediatrician, you will know that as well.
Yeah, sure. And yesterday we have very good discussions and a very good thing. And I hope we will continue that today also. And with authority like Mattu sir is there, so we have new addition and new perspective we will know. So thank you, sir, for giving us a time. Thank you.
Thank you, sir. Thank you very much for organizing this webinar. This is really needed. This is a very important topic and critical component of the program, and we need to have some deliberations on this.
Yeah, sure, sir.
Dr. Rakesh is also there. Good afternoon, Dr. Rakesh.
Hello, sir. Good afternoon. Good afternoon.
Thank you for being again. That's great.
Thank you. Thank you, sir.
Good afternoon, Rakesh sir.
Hello, sir.
Yeah, great. Yesterday you are driving the session so fantastically. So,
Thank you.
and all discussions are very good, and all your comments and they are so well pitched up and so pointed out. So I think even on those thoughts also we can have the another meeting for 2 days. So it's really
Swati,
good.
Dr. Shibu is here. Swati, Dr. Shibu is here. Will
Yes,
you like to start?
yes. Dr. Shibu is also here. So I think we'll start today's meeting. Warm welcome everyone to the second day of PRERNA Science meeting on pediatric TB. We have our Honorable ADDG of TB, Dr. Sanjay Mattu, and all other eminent panelists with us. We are joined by the young scientists and their faculty from all the three centers of the PRERNA group, CMC Vellore, CHRD SAS Delhi, and KEM Pune. We also have few participants joining in webinar mode as well. We are streaming live on our YouTube channel of KEM HRC. So start today's meeting with a quick short recap of one of our young scientists, Dilesh Kumar from CMC Vellore. Dilesh, please of
Hi,
yes.
good afternoon. So yesterday this wonderful session started with Dr. Varinder Singh's real world experience. I mean, he's got real wealth from both TB as well as little bit on undernutrition and HIV. So he's given us that the full depth on how much we should expect and where we are in TB. And he actually dwelled on current diagnostic algorithms. What are the new diagnostic methods which are available coming up now, and how is the treatment progress in children, and how are the formulations changing, and how it is actually enabling the big battle against TB. And so this he also touched upon how the adherence and treatment completion also. And followed by that, we had quite a robust discussion on with Dr. Aparna Mukherjee as well as Dr. Aishwarya and Kristen Ho coming in with experiences from their side, especially with Dr. Aparna Mukherjee giving us comparison between diagnostics, how the Expert Ultra and PRERNA really performs in real world scenarios. And there was also a discussion about chest X-ray and AI-enabled tools, which are really helping us. And there was a brief discussion on stool samples, especially from the professors from Bangladesh and their experience on how stool samples have performed in Expert. And Dr. Aishwarya gave us the vaccines in the pipeline and how the WHO initiative is really gearing up research to procure TB vaccines for us, and where we are in terms of a vaccine pipeline, when we are able to get that and all those things. And lastly, Christian Ho gave us international perspective on how TB infection rates are, LTBI, and tests available, and how is the utility of the CAR tests and the different regimes used, and how is the risk resistance across countries. So that's where we stopped last yesterday evening, and I hope that we'll continue more discussions this day. We're looking forward to the discussion. Thank you.
Thank you so much, Dilesh, for summarizing yesterday's sessions. We had an overwhelming participation of almost 162 people yesterday, and we are getting very good feedback from the attendees. So hope to continue the sessions, interesting sessions today also, and I'm sure about it. So today, let me introduce you to the chairperson of today's sessions. I'm very happy to have Dr. Shibu Balakrishnan from WHO. So Dr. Shibu Balakrishnan is an anesthesiologist by training and has 25 years of work experience in TB. He is currently the National Professional Officer for TB Partnerships at the World Health Organization Country Office for India. He also serves as a TB consultant to the USAID, the Global Fund, the Stop TB Partnership, and is a serving member of Technical Review Panel of the Global Fund. He has previously served as the regional team lead for WHO India TB Technical Support Network in South India, and also as a national consultant for DRTB in NTP at the Central TB Division. So his stellar career achievements include contributing to the development of standards of TB care in India, TB partnership guidelines, PMDT guidelines, NTP technical operational guidelines, and the successive national strategic plans in India. So his publications are on TB, diabetes, practical approach to lung health, TB treatment adherence strategies, steps, and subnational TB burden estimation in international peer-reviewed journals. He has led various independent assessments of TB program components in multiple countries like Indonesia, Philippines, Cambodia, and so on. It's a pleasure to have you with us here, Dr. Shibu Balakrishnan. Welcome, and over to you.
Thank you, Dr. Swati. It's indeed a pleasure to be with you today. Basically, I understand that this is a good research group, very enthusiastic, and whatever I have heard from yesterday's recap is that there have been excellent presentations from the eminent panelists from different fields, and there have been very interesting, very much encouraging responses from our audience. Great. So let us see how do we do today. I will not take much time for an introductory remark because there is an opportunity for summing up the sessions. So I don't keep our panelists waiting. What I do is, the session is on pediatric TB. The session is on various aspects of pediatric TB, about what NTEP is doing in that area, to understand how the public and private partnerships are supporting the pediatric TB care, and India's ambition to end TB by 2025. And also the systems approach to pediatric TB and some of our experiences with pediatric TB or the TB affected children. Unfortunately, one of our panelists, eminent panelists, was not able to join us today, but let us try to keep our time as scheduled. So now this is almost 2 o'clock, 10 minutes past 2 o'clock. So as scheduled, we will go ahead. I first request Dr. Sanjay Mathu. Dr. Sanjay Mathu is a National Senior Program Manager. He is the Additional Deputy Director General TB in the Central TB Division. He has been there in the Central TB Division since 8 years, and he has a lot of experiences in different sub-portfolios of the program. He has been into extrapulmonary TB, especially the pediatric extrapulmonary TB, the TB comorbidities, private sector engagement, NICSHA, and the research in TB. So he is also a clinician and a public health expert. He has published a lot of important publications in the international peer-reviewed journals. So today we are going to hear from Dr. Mathu about how NTEP is doing in the area of pediatric TB. So welcome, Dr. Mathu, over to you.
Thank you, Dr. Shibu. And first of all, I would like to congratulate this PRERNA team for organizing this webinar and having the discussion and deliberation on a very critical component of the National TB Elimination Program. And I would like also thank to the panelists and the again PRERNA team for providing an opportunity to me to make a presentation on the programmatic overview about the management of the tuberculosis in the pediatric age group. So I'm just sharing my slides and Is my slide visible? If someone may confirm.
Yes, sir. Yes, sir.
And let me make into the presentation.
You have to put it on slideshow.
Yeah. Is it in slideshow mode now?
Yes, yes, sir. Yes, sir.
Yeah. So great. Basically, we are having this management of the pediatric tuberculosis in National TB Elimination Program. We are having our national strategy also for this particular program, and this pediatric is a very critical and very challenging area, basically, if we want to consider. So I'm just starting my presentation, and if you want to see the burden of the tuberculosis in India and the globally, so we are having this global disease burden reports are there. One was published in 2010 and another one was in 2019. And respiratory disease and the TB, they were placed at the third place in 2000, and now they have moved to the fifth position. And you can see, if we are seeing the major public health problems, there is a graph on this, and this graph is showing this red circle is basically showing the tuberculosis burden, and other it is second only to the diarrheal diseases if we are seeing the major public health problems. And when we are seeing the tuberculosis situation in India, so you can understand, like, we are having almost 10 million cases are there world over, and almost 28% of the tuberculosis cases are contributed from India. And this is the global data, and this is column is showing the Indian scenario, and this is showing the percentage contribution from India. So at present, if we are saying almost 3 million cases are expected from as per the global TB report, it is a 22 report which is data has been shown, and as per this report, almost 3 million total number of cases are expected. And if you want to see the per 100,000 cases population, how many cases are there? 210 is the number as per that report. And if you want to see the HIV TB cases, how many HIV TB cases are there? So 54,000 cases were reported in 21, and mortality as per estimate, again this is a not actual figure, this is estimate, which is 4,94,000. And if you want to see the mortality notified, it is almost 90,000 cases were notified of the mortality in the program. Nearby 90,000. And if you want to see the contribution of the total TB notification, India is contributing 28%, and contribution to the HIV TB cases is 6%, and mortality because of the tuberculosis total contribution to the world over mortality because of tuberculosis is 35%. So we can understand that a very large number of the mortality and the TB cases are occurring in India, though the situation is not as bad as it is shown in this slide. Basically, if we want to rank ourselves as per the TB burden per 100,000 population, India is placed at the 35th rank. So there are the 34 more countries are there who are having more incidence rate and or higher incidence rate than the India. But because of our population size, this figure is coming of the having the most number of the tuberculosis cases in a country. Now, when we are dealing with the childhood tuberculosis, so a situation becomes more critical because there is a large number of the missing cases are there which are in community, and there are some global data is there. Like if you want to see the globally, it is estimated that around 60% of the children with the tuberculosis are never diagnosed. And then 96% of the children who die from the tuberculosis, they were never put on the treatment. And if we want to see of these children who were not put on the treatment and died because of the tuberculosis, 80% of them belong to the age which was less than 5 years. Then if you want to see that how much is the load of the tuberculosis in India, almost 12% of the tuberculosis are contributed by the pediatric age group to the total TB cases in India. When we are having estimated number, so again this is the as per the global TB report, And in 2021, as per the 22 Global TB report, almost 3.5 lakhs TB cases were expected. And if you want to see how many has been notified against this estimated number of the pediatric tuberculosis, so only 1.20 lakhs pediatric tuberculosis were notified by the program. So you can understand like over figure of the missing cases almost matching with the tuberculosis cases which are missed world over. And then the case notification gap is highest when we are seeing the particular age group, which is the 0 to 4 year. In this, on the right hand side, we can see this figure. This orange bar is showing the percentage of missing cases, and the blue portion is showing the percentage as a percentage which has been notified under the program. The first column is 0 to 4, then 5 to 4, and more than 15 years. And this is bar for the tuberculosis in all ages. So you can see that when the missing percentage is almost 38% in the all ages, it is more in the children age group, and it is more severe of when we are seeing the missing cases in 0 to 4 years. Now, if you want to see like as a percentage, we know that almost 12 to 13% of the tuberculosis burden is from the pediatric age group. And we want to see how the program has performed as per the notification over the years, like from 2012 to 22, how much tuberculosis cases has been contributed by this particular age group. So it is not very pleasing figure. Almost we can understand that this is we are hovering around the 6% only, except in the 2019 when it was 8%. So almost we can say that 50% of the tuberculosis in the pediatric age group still are not notified in the program, and they are somehow missed. Either they are dying or they are not being treated. So that is the situation with regard to the pediatric tuberculosis. There are the certain challenges basically. Is somebody asking something? We may have the questions at the end of the session, and meanwhile we may request to mute the may request the participant to mute their mic. So when we are having this pediatric tuberculosis, there are certain challenges are there, like there are the certain anatomical, immunological, and epidemiological factors which make the clinical presentation and investigation of the tuberculosis in this age group very challenging. Like we are having smaller airways are there, then usually it is very difficult to obtain the sputum sample from the children. Their airways are small and they cannot expectorate this sputum, so it make more challenging. Other factors are most of the time the disease is possibly in these children, and other than this possibility disease, usually we find the disseminated or the extrapulmonary tuberculosis in the young children as compared to the adult populations. Then there are the other predisposing factors, like undernutrition is a very big risk factor for the development of the tuberculosis, and we are having NFHS 5 data where it is showing that almost 32% of under 5 children are having this undernutrition. So it is highly prevalent, and that is why they are more prone to have this tuberculosis. Another factor is like most of the time the TB patient and the children, they stay at the home, and that is why they are having the longer period of the exposure, and they are more prone to get the infection from the infected person who is having disease. Then the test available, they are not having the sensitivity as it is in the adult cases because of the possibility nature of the disease. And then we are not having experts in adequate numbers, and usually if the specialists we are seeing, they are placed either centrally or at the district headquarters, and a person who are sitting at the last mile or even at the block level, it is very difficult sometimes to find this pediatricians to make the proper diagnosis and treat the patients in right time. So how now we are following this diagnosis of the tuberculosis in the under the programmatic setting. So we are having programmatic guidelines defined. There is an algorithm which need to be followed. Like we are having definition for the presumptive pediatric tuberculosis in the program, and any person or the children who is having these symptoms should be investigated. Like if fever is for more than 2 weeks, cough is also for more than 2 weeks, and a significant weight loss is there, or there is no weight gain in past 3 months after the person, this child, children, they are taking the adequate nutrition, or there is a failure to thrive or gain weight. That is the symptoms which suggest that the children might, or the particular child might have this type of tuberculosis, pulmonary tuberculosis. Earlier, there was a history of contact in the family was an important factor, but in this new algorithm, we have said that if history is present, then it's okay. If it is not present, then also we need to go for the investigation. Then chest X-ray is done upfront, and after that, this net is provided, and we are not doing the microscopy because the samples are precious in the children, and we don't want to waste the samples on the microscopy. So directly we are putting this net test. This net test as a policy now, even in for adult, we are advocating that upfront net is to be offered for all type of the age groups, not only in the pediatric. So, but children definitely as a special group, we are offering that they need to have this a net definitely to be provided for this age group cases. Then gastric lavage and induced sputums are the specialized procedure because it is very difficult to obtain the sputum in the children who are up to the 8 year of age group. Beyond 8, usually the children may expect it, but in the lower age group, it is very difficult. So these special procedures are needed, and usually we need to have the trained manpower. Then we are having some community supporters who are supporting that for early identification of the presumptive TB cases. They are having some certain checklists are there, and Anganwadi centers are there where ASA and this community health officer at the sub centers and in the PHCs, they are usually doing this screening and sending these presumptive tuberculosis to the right place for the proper and prompt diagnosis. Then we are having under the program this diagnostic and treatment services are free of cost, and they are provided to all kind of patients, whether they are identified in the public health sector or the private health sector. So it is available for both public and private health sector as a free of cost. So this is the diagnostic algorithm which we follow under the program, and I think this must have been displayed yesterday also. Dr. Varinder and a team was there who particularly supported Central TB Division to design this particular algorithm. And so as we mentioned that we have to first identify the presumptive tuberculosis cases, and as we are not having this specialist at the peripheral most center, so we are first doing the chest X-ray, so that whenever the patient from these peripheral site is to send to the specialist, the chest X-ray is available, and that this specialist make some decision on the basis of X-ray also. So after this X-ray, we are having three arms are there. Like if X-ray is highly suggestive, then definitely we have to this molecular diagnostic test. Person may be net positive, and if net positive, they are giving the rifampicin sensitivity results also. So accordingly, we are putting patients on the as a RS case, rifampicin sensitive case, or rifampicin resistance case. They are being treated. In case negative, then the it moves to the right hand side limb, where we are having this chest X-ray is non-specific, shadows are there, and in those cases we are initially providing some antibiotic courses, so that we want to see if it is a non-tuberculosis infection or not. And in those cases, when we are providing this antibiotic courses, it has to be a non-tuberculosis, anti-tuberculosis antibiotic is to be provided. After this course, even if that symptoms or shadow persist, then again we try to have some uh, uh, rule out that if tuberculosis in other sites, in extrapulmonary site or in the lymph node, we may take the aspirates or the samples from these sites and try to find out this mycobacteria. We may have some better quality specimen like from the bowel or the other aspirate, bronchial lavage or other aspirates. And then if it is the higher centers are available, the patients may be referred to those centers to have the opinion. And again, if we are finding these samples to be put on the NET test and NET is positive, then they are to be treated as a microbiological confirmed TB. If still the NET is negative, then we move to the third limb where we are having third limb is basically chest X-ray is normal. In such cases, we need to rule out the extrapulmonary tuberculosis. We need to think of some alternative diagnosis also. CT chest may be done and other investigation may be done to rule out it properly. We may consider to have the opinion from the higher centers to have the proper investigation. And if other likely diagnosis has been ruled out, then we can treat such patient as a clinically diagnosed probable TB. So, because clinical diagnosed cases may be on the basis of X-ray, where we are having shadows are there and they are highly suggestive, and this may be treated as a clinically diagnosed TB, and there may be the clinically diagnosed probable TB. So that is how we are following this algorithm. Now, when we are giving the services and the treatment under the program, we are providing the medicines. So, because there are the many challenges are there when we provide the adult formulations. So, under the program, we are having child-friendly formulations are there, and there is the fixed dose combinations. And usually, we are having these medicines in the different flavors are available. 3 to 4 flavors are there, and we are providing a flavored child friendly pediatric fixed dose combination as per in the programmatic settings. And as mentioned earlier, these medicines are free of cost to both the public and private health sectors. We are having high quality drugs under the program, and we are following it may be as per the British pharmacopoeia, US FDA pharmacopoeia may be there, India pharmacopoeia. Either of the pharmacopoeia may be used by the manufacturers, and definitely they need to follow the WHO GMP parameters. And over DCGI is the regulatory authority for this quality parameters. So those CDSO regulations are also to be complied by the suppliers. So all these standards are to be maintained, and we are ensuring when the procurement is done that all these quality parameters are met by the manufacturers. It is a procurement done at the center level, and then it is supplied to the state, district level, and goes lower down to the peripheral health institutions where we are giving the medicine, and it is called as the dot centers. So why we are having these FDC? Basically, the dosage of anti-tubercular drugs have been revised because you cannot give the same concentration as you are giving in the adult formulation. So usually you need the if you want to see the per kg body weight, the medicines are needed in higher side dosage. So that is why these dosage has been revised. And when we are saying these adult formulations, basically you have to break, and if you are breaking, usually the active ingredient is not uniformly distributed in these tablets. And while you are breaking, you cannot ensure that if the required concentration of the medicine is reaching to the children. Other than this, these medicines are not palatable or easy to digest. Usually children vomit, and the pharmacokinetics and pharmacodynamics of these adult formulations is different. That is why these FDCs are needed. Why? What is the other advantage of these FDCs? They are safe and make the treatment simplified because it avoids the errors in missing one or more combinations of the drugs. Because if you are giving loose drugs, sometimes the children may or the parents may forget to give a right number of medicines to the particular children, and it reduces the development of the drug resistance tuberculosis also. Now, when we are having pediatric dosage and drug formulation, so this is just for information, like we are having in intensive phase, we are having 3 drug FDCs there, and in continuation phase, we are having 2 drug FDC. The ethambutol is hygroscopic, so it cannot be combined in the FDCs, and it is being provided separately. Then when we are giving these drugs up to the 8 year of age, usually it is very difficult that adult formulation will not work, and that is why this up to the 24 year of age, definitely the child friendly formulations are to be given. Beyond 24 up to 39, a combination of the child friendly and adult formulations is given to decrease the number of the pills. And when children are more than 40 kg of weight, in those situations, the children are giving the adult type of formulations are to be provided. Whenever a person is in the treatment and the children they are gaining the weight, so the change in the respective weight band is to be maintained, and then the right quantity of the drugs are to be given. And pyridoxine is provided as a supplementation in the children's for the treatment of the tuberculosis also. And if we are providing this TB preventive treatment, the TPT as a chemoprophylaxis, where we are giving this isoniazid preventive treatment, and dosage of the this pyridoxine has to be 10 milligram per day. We had a expert group again of the pediatricians, where we want to see that what can be the best child friendly formulations. So this is the ranking of the child from friendly formulations. Like if you are having scored disposable tablet, that is the best one. If it is non-scored disposable, then second. Syrup comes at the next place. If it is not there, then score tablet, because it is easy to break. Then after score tablet, the capsule is there. You can make the portions, and if it is not there, then last in the ranking is the film, which are coated tablet or gel capsules. So this is the, and basically in DSTB we are having these FDC and child friendly formulations, but in DRTB we are facing some challenges to procure these child friendly formulations. Either manufacturers they are not coming, because a particular type of medicine may be needed for particular regimen, and the quantity may not be so large. So these manufacturers see their benefit, and that is why they are not coming with these child friendly formulations. So for these DRTB medicines, we have made these scoring of the child friendly formulations, like if ideal is not there, what may be the next option. And this was again done by the pediatricians, where we are having our expert group is there with the National TB Elimination Program. So through that we get made this particular ranking. This is the number of the tablets, how it is to be given as per the body weight. Like we are having 4 to 7 kg band is there, 8 to 11 kg, 12 to 15. And then next column is showing the number of doses, like one pediatric FDC and then one ethambutol loose. And in cases when this more than 20 kg of body weight is there, in that we are using this adult formulations also. And where this weight is more than 39 kg or 40 kg, then we can use the adult formulations. And lower down, it is the comparison between the adult FDCs and the pediatric FDCs. What is the strength? So this is just for information, like what has to be the active ingredient concentration in the adult and the pediatric formulation. This particular slide is showing how the pediatric DRTB is managed as per the programmatic guidelines. So either we may have this rifampicin resistance case or the multiple drug resistance case, where along with the INH rifampicin, some other drugs may be there which are resistant. Then we are having INH monopoly. In INH monopoly, basically either INH as a single is resistant, or they are the other drugs also in the poly along with the INH, but not the rifampicin. If rifampicin is resistant, then it will go to the upper arm. So in MDR, rifampicin resistant tuberculosis, uh, either it may be the pulmonary cases where it is not very extensive or disseminated, and non-severe extrapulmonary TB cases, we are having this regimen where this shorter oral bedaquiline containing regimen may be given to the children who are more than 5 years of age. But in India, we are not having this DCGI regulation for use of the bedaquiline for the children who are below 5 years. So we are having the second box is there, this one which is without bedaquiline. This may be given. This 4 to 6 is giving this, that for the 4 to 6 month we have to give this particular regimen, these drugs. After 4 months, it may be extended up to the 6 months, depending on the if you find the bacteria in the monitoring after this 4 month period. And of this regimen, bedaquiline definitely has to be provided the 6 month. Whenever we are giving bedaquiline, it is to be given the 6 month, and for next 5 months we may give these medicine. This is the short regimen. When we are having this regimen without bedaquiline, then we are adding this monofloxacin, and injectable is also to be used in such cases, and then 5 months of this is there. So this is when we, because in the less than 5, bedaquiline is not approved for use in the children less than 5 years. If MDR-TB is disseminated or very extensive pulmonary tuberculosis there, or we are having this pre-XDR cases, in such cases, if children are more than 5 years age, then we can give this longer all oral regimen where the bedaquiline is part of this regimen. It is to be done 18 to 20 months. And if it is less than 5 years, then bedaquiline need to be replaced with the group 1 with one medicine from the group C drugs. And to know that, we are having TBC India website is there, and we are having this module is there for programmatic management of drug resistance tuberculosis, from which you can note down that which are the medicines which fall in this group 1C. Then for INH monopoly, we are having this 6 month regimen is given, where levofloxacin, rifampicin, ethambutol, and pyrazinamide is given. And these regimen may be modified as soon as we are getting this approval for the bedaquiline for use in the children who are less than of 5 years age group. These two boxes will be modified. So in current scenario, this is there, and it may change subject to the bedaquiline approval for use in the children with age less than 5 years of age. Then this was the programmatic thing which we are doing now, because as this national TB program, we are having the targets is very high, and the pediatric tuberculosis is a such situation it is very difficult to find, because we are having under the programmatic settings, either these pediatricians are at the tertiary care hospitals only, or in the medical college or the district hospitals. It may be very difficult to find the pediatrician in the CHCs also. Many of the CHCs, they don't have the pediatricians. So that is why we need to have the collaboration with other health programs. Then along with the other health programs, we have to have the engagement with the private health sector, so that we can have this partnership with the private pediatricians, so that a proper management of the cases and the maximum number of the cases may be identified. So therefore, we are having a certain programs there under the National Health Mission program, where we are having collaboration. Two such programs are under this Child Health Division, where we are having the Rashtriya Bal Swasthya Karyakram, and we are having Rashtriya Kishore Swasthya Karyakram. So this is for adolescent group, and this RBSK. So, and then we are having one collaborative framework with the National Rehabilitation Center program also there, where the severe malnourished child are to be treated and given the nutrition. Then we are having a collaboration with the Ministry of Women and Child Development, where these nutritional missions are there and the Poshan Abhiyans are being organized by these uh, ministry, and we are having collaboration so that these mobile health teams of the RBSK and the in adolescent friendly clinics and the RPSK, some screening of the symptomatic TB cases may be done, and then proper linkages may be done, some awareness and IC material is provided so that they can know about the tuberculosis. That is how they are supporting. Then under the Ministry of WCD, there is the one ICDC scheme is there where Anganwadi centers are there, and Anganwadi workers are also trained to do the screening when the children are reaching there. Then we are having engagement with the private sector so that more and more pediatrician may be there for this. We are having one patient provider support agency is there, which works as an interface agency between the public and private sector and support notification, treatment supports, and other kind of supports are there which are provided by these PPSAs. We are having one MOU was also developed with the Indian Academy of Pediatricians to have the certain trainings at the in the public health sector and the private health, so that we can have more and more trained manpower among the pediatrician also, so that right kind of diagnostic algorithm and treatment may be given by these trained manpower. Then we are having a concept of this center of excellences for the pediatric tuberculosis, and we are having 7 center of excellences are there, like 2 national center of excellence are there, and 5 regional center of excellence are there. They are basically supporting the program in the training manpower at the state levels, lower down, and they are providing this treatment in difficult to treat cases also, and then they are supporting in the monitoring also. So that is how these center of excellences are supporting this particular management of the pediatric tuberculosis under the programmatic settings. Then if we are just going to identify the cases and treat the cases, it will not give us the leverage, and it will be very difficult to achieve the SDG targets, this NTB targets of SDG. That is why this preventive aspect is very important, and this TB prevention is very important, and we have to do the TB prevention in the all age groups. So earlier there was the only 2 groups were there, like PLHIV and less than 5 years. Now we have increased the scope, and then we are having certain tests are there which need to be performed where the children are more than a 5 year of age, or if they are not having HIV infection. The 2 tests at present, like IGRA is available and CyTB is there. This is again the skin test. TST test is not available because this PPD which is needed for the TST is not available. So we are having IGRA and CyTB, and program division is in process to procure this CyTB. Soon it will be available. At present it is only IGRA test which is available, though it is costly. What is the strategy? If we are having household contact under the 5 year of age, or we are having children who are having HIV infections, or even the adult who are having this HIV infection, they are provide this TB preventive treatment without testing. And whenever we are having these children who are more than 5 year of age, or adults who are not having this HIV infection, then the testing is to be done, and then a treatment is to be provided. What is the treatment available? So we are having like treatment options are 6 months of INH is there, and 3 months of INH and rifampicin is there, where it is weekly dosage is to be given for 3 months, and there are the 12 weekly doses are there. These 3 HP can be given if children are older than 2 years of age, because it is not approved in less than 2 years of age, rifampicin. So that is why it cannot be given. So this is the TPT where we have to give to the children. Then these are the doses of the rifampicin and the INH when we are giving the doses. So this is just for the information that if you want to have this information, it is also available on our TBC India website, where we are having a PMTPT module is there. From that, it can be obtained from that website. Then other than this, we are providing certain support to the patients also, like we are providing Nixaposan Yojana is there, where 500 rupees are provided to every TB patient, and it is to be provided till the treatment is given, like it may be 6 months or it may be longer depending on the monitoring status or the DRTB status. Then we are providing certain benefit under the tribal support scheme. One time 750 rupees is given to the tribal TB patients. Treatment supporter honorarium is also there, where this community members who are supporting, or the some community influencer who are supporting these TB patients to take the medicines, and if some ADR is there, they are referring or sending these patients to the right kind of facility for proper management. Then a treatment supporter honorarium there, 1,000 for DSTB and 5,000 for DRTB patients. And we are having incentives for notification and outcome assignments also, whenever these TB patients are notified in the private sector. 500 is given on at the time of diagnosis notification, and 500 at the time of the outcome notification. Then we are having a group of TB Vijetas or TB champions. Basically, who are these TB champions? When these TB patients are cured of their tuberculosis, they are called the TB survivors. We are providing some kind of sensitization trainings, and after these trainings, they become the trained TB survivors. We call them TB champions under this term, and now they are called as TB Vijetas. These TB Vijetas, because they are from the same community, the acceptability of advice, whatever they are providing by the community is high. So they are supporting us in identifying the tuberculosis. Then they are acting as a TB supporter also. They are providing some counseling also TB to the TB patients, and they are the important link when we are having this community support at the community level. Other than this, we are having National TB Forum also, where this community, Panchayati Raj institutions, and the other, even the community from the different minor gender identities or the sexual identities also representing these TB forums to put up their ideas. And these TB champions are also member of these TB forums, where they are providing right kind of inputs, and in every stage of the programmatic management, from planning to the service delivery and monitoring and evaluation. Then other than these TB champions, we are having ASA workers are there, multi-purpose workers. We are having auxiliary nurse midwives are there, who are supporting in case identification. Then along with the case identification, referral to the proper site. They are supporting in active case finding also. They are supporting in the specimen transportation also. They may act as a treatment supporter to the TB patients, where they are making it sure that the TB patients are adhering and completing their treatment, and they are taking the full course of the anti-TB medicines. And if some ADR is there, then they are taking these patients to the right kind of facility for proper management. They are also supporting in the preventive measures also, and then they are supporting in the generation of awareness among the community about the TB symptoms, and they are supporting in some having street plays. They are supporting in the Anganwadi centers also to sensitize and to find out the early cases of the tuberculosis. Then there is one more important activity which is there under this community support, which is basically Pradhan Mantri TB Mukt Bharat Abhiyan. This was launched last year, 9 September was the date, and it was launched by our Honorable President. Under this scheme, basically, community are coming from themselves. They are highly motivated communities. They are supporting the TB patients, they are adopting the TB patients. And when we are saying adopting TB patients, basically they are providing the nutritional support, which is already other than which is already in the program, like 500 rupees we are already giving. But there is kit is there, which may be provided on the monthly basis. The kit is not of very high cost. Up to 500 or 600 is the cost of monthly distribution. Other than this nutrition support, they may be supported for investigation or for the diagnosis of the TB patients whenever the services are not accessible to the TB patients. They may support in the as a vocational support, and some vitamin or nutritional support may be provided to these TB patients. And basically, not only these support, this particular activity is decreasing the stigma, because tuberculosis is still carrying high stigma in the community, and when the community is coming forward for such adaptation and providing these kind of support to the TB patients, this stigma will reduce. And definitely, because in the National TB Prevalence Survey, it was observed that almost 40 to 60% were the such patients who were having the symptoms, and they did not approach to the TB centers for proper diagnosis and management. Either it was because of the stigma, they did not want to diagnose TB cases, or it was because of the lack of awareness that these might be the TB symptoms. So that is why this Pradhan Mantri TB Mukt Bharat Abhiyan may support in reduction of the stigma also, and definitely it will give more and more cases and will support to move towards this NTB targets, achievement of the NTB targets. So this was from my side about the programmatic update. There are certain research priorities also there, but because I have already crossed time, more than time given to me, so I will leave to the panelists, because I can share these slides and these topics may be taken. If you want to see that research priority in, we can look for the some newer samples, because technologies, as you know, that a sample obtaining of the sample is very difficult in the children. So this is one thing. Then other than this, we can think of some biomarkers which can support in the monitoring of the TB patients, how they're progressing, if they are cured or not. So these are certain areas are there, but I'm stopping here because of the lack of the time. Thank you very much for patient listening. Over to the panelists.
Thank you, Dr. Mottu. That was quite impressive trade presentation, and that has helped, I'm sure, to give a clear understanding of the program, what the program does for combating the TB in children. Okay, so before I open up to the floor for questions, let me ask a question to you, Dr. Mottu. Because you have a great lot of institutional memory. You were traveling with the program since a long time and was instrumental in taking many of the policy decisions. So if you look at the diagnostic algorithm of the pediatric TB, and let me also congratulate the pediatric TB experts group at the national level, including Dr. Varinder Singh, who is the voice of the children in India. So that's an excellent algorithm. So in that, X-ray is a very crucial tool to diagnose TB. Before we move the specimens to molecular test, X-ray is very crucial. So my first question is, how does the program, or what is the program doing in enhancing the access to X-rays? Similarly, the second question also is a part of the first one. That is, how is the program enhancing the access to molecular diagnostics in the periphery? The third, again, attached to this, these questions are that also the pediatric TB management needs a lot of capacity in the field. So what is the program doing in building the capacity? for diagnosis and management of the clinicians in diagnosing and management of pediatric TB. So first question is on the X-ray axis, second question is on the diagnostic axis, third question is on the capacity of the clinicians. I know that program is doing some excellent initiatives in this regard. Over to you, Dr. Mark.
Thank you, Dr. Shibu, for asking these questions. So, first question with regard to accessibility to the X-rays. So, like program recently has the digital X-rays, and digital X-rays are providing better quality. They are the printout may be taken, and this soft images are there. So this is one thing, and almost all the district headquarters are having this digital X-rays has been provided through the centers. But this is again at the district level where we are ensuring. Then lower down we are having CHCs are there, PHCs are there. We understand that all of the CHCs, they don't have the X-rays. What we are trying to have here, the program division is in process of having this digital X-ray technology. We are exploring all the options, and if these digital X-ray may be made available through this mobile van schemes, and where the X-rays are noted, so we are thinking that if such access may be made available. So this is one option. Other than, like, already we have ensured that at least each district has to have the digital X-ray machines. Second is that we are having this mobile van where this X-ray is mounted in the active case finding mobile vans are there. Then third option is that program is exploring to have this digital handheld X-rays which are there, and it is easy to take to the field. That is in process. Other than this, we are having voucher schemes also there. Provisions under the programs are there, where we have left to the states where they can decide. The program team, state program team can decide to have the some agreement and collaboration with the private health sectors where these X-ray machines are there, and one rate may be fixed, and as per that rate and under the programmatic provisions, the voucher may be given to the TB patients. They may reach to such a private health facility for the X-ray to get the X-ray done. This is another option. Now coming to your next question with regard to the net availability. So yes, as of the programmatic decision from very starting, this upfront net for the pediatric age group was we can say it was a rule for the pediatric age group that upfront net is to be provided all the pediatric samples. But now we are having almost we can say that of around 6,000 molecular diagnostics are available under the program. So 6,000 we have already covered up the blocks level availability is there. Okay. And we want to achieve this 8,000 machines are to be needed, because if we are having these 8,000 blocks are covered, almost these 8,000 scatters almost 80 to 85% of TB loads are there. So program division is also in process of having this 2,000 more machines, and that is how the situation is. So you can understand that block level availability of net is there, and you can understand almost blocks who are having 80 to 95% of TB load that can be catered through the net upfront. Remaining 15%, yes, that is challenge. So for those we are having this sample transportation mechanism is there, either through human carrier, postal carriers. Under those provision, program provide this monetary support, and samples may be transported to the proper facility. Now coming to the third question about capacity building under the program. So first thing is that under the TB program, this availability of pediatrician is usually at the center, either it is a medical college or district hospital, tertiary care hospitals are there. And as I mentioned earlier, even many of the CHC, they are not having this pediatrician. And a pediatrician become very critical to have the appropriate diagnosis of the tuberculosis, as sample is not usually available in the pediatric age group. Usually it is the clinician experience, proper reading of the chest X-ray, and on those basis only this diagnosis is to be made. To cover up these gaps, basically we had an MOU with the IAP, Indian Academy of Pediatricians, where they were supposed to conduct a number of the CMEs. And under these CMEs, both the pediatricians, even the medical officers of the PHCs and the pediatrician of the public health sectors, both were supposed to be trained as per these newer and updated guidelines so that everybody is acquainted with the updated information on the diagnosis and treatment and can do this thing. Other than this, we are having concept of the pediatric center of excellences. As I mentioned in my slides, we are having 2 national level pediatric center of excellence and then 5 regional. These center of excellences also train, basically lower down, they will provide the training to the state level pediatric center of excellence, and that further will train to the district level this experts in the pediatric age group management of the TB. So that is how we are planning this particular filling up of the gap. Right.
Thank you so much, Dr. Matu. That is very clear about the X-ray capacity, access to X-ray, about the molecular diagnostic access, and about the capacity building. So now we can take, in the interest of time, we are not permitting too many questions, but we can take 3 questions. I see a question from Dr. Bharti Khainar in the chat. It's about the urine lamp, comment on urine lamp. I think this is slightly beyond this topic of the program's approach to pediatric TB. But I would request an expert, national expert, to quickly comment on. Dr. Varinder, if you are available, could you please comment on this quickly?
So if Dr. Varinder is not there, I can give some. Yeah, he's there. I said Dr. Varinder is there.
Yeah.
So basically, it is one ingredient biomarker which is used by the whole type of mycobacteria, not only Mycobacterium tuberculosis. This is one thing, and this basically because it is a biomarker and is available in all type of mycobacteria. It is just used in the persons who are having HIV infections. Because in HIV infection it is difficult most of the time it is post-bacillary tuberculosis and it is very difficult to find this bacilli. So and when the CD4 count is low, in those cases this biomarker can be identified at early stage, and on the basis of this treatment initiation may be done. So this is the role that to start in the anti-TB treatment in the persons who are having HIV infections. After that, the normal algorithm for diagnosis of the tuberculosis to be followed, like a NET test to be done on the samples for other things. Otherwise, because you can understand that any mycobacteria may give this particular type of test positive. So this is little bit of information which I am having at present. As a programmatic decision in the HIV persons to use this as a test, one study is being conducted by the ICMR, and after that validation it is to be implemented. WHO is recommended, but it is not used in India. WHO recommend among the PLHIVs who are having supposed to have the TB infection. Still, we are not using in the PLHIV in India because ICMR validation is to be done. After that, we are going to use for the PLHIV.
Yeah, thank you, Dr. Matu, and that's very clear. So there are.
Sir, Dr. Varinder Singh is here. He has messaged in the chat.
Yeah, I've seen that. So, Dr. Varinder, sir, please, if you have some more comments on the urine lamp, please go ahead.
Yeah, thank you. Urine lamp is largely a antigen detection test, which is done by lateral flow assay. And as Dr. Matu very rightly pointed out, validated only with HIV. And one of the difficulties with lamp, whether it is urine or otherwise, is that, or even lamp, which is a very different kind of test, which is more on a bacteria, is that they do not tell us about rifampicin sensitivity. And currently the program has moved on from a diagnosis of establishing also about rif resistance as UDST. So as Dr. Mattu also pointed, that it's not perhaps enough to know it is TB. You need to work more with the tests which are able to give you optimal information on whether you should be using a DSTB regimen or a DRTB regimen. So that is where the effort is directed towards tests which are more giving nested information about it. Thank you.
Thank you so much, Dr. Varinder, for that additional inputs. One question in the chat is about from Dr. Rituja Patel is about Dr. Mattu. It's about the program's activity. Does the program plan to assess and overcome the implementation level challenges? And there are some examples are given here. Increasing coordination between the NTEP staff and the health system staff. Yeah, that's a systems approach. Second, monitoring of the training activities of ASHA before the ACF rounds. So there are some examples given. So at least your inputs on how the program tries to address the implementation challenges like coordination between the NTEP staff and the system staff and in enhancing the capacity of ASHA.
Yes, these are valuable inputs, and definitely we are trying to have this. But when we are in this systems health staff, like not NTP staff, usually after the sensitization training, also doing monitoring, it was observed that participation from their side is very dismal, and reporting and recording is not there of their activities. So that is how the situation is placed, and we have requested state teams also during meetings. MDNHM was also requested, and it is not giving more fruits as it is expected. So that is the challenge basically. Like they're saying they are already busy in their own activities, and they cannot spare the time for this. That is the usual response, and motivation level is not there. But definitely these are valuable inputs, and we will take these inputs in our programmatic activities. Right.
Thank you, Dr. Mattu. And let me also reassure the entire participants of this webinar that the program's outlook to the general health system is not that NTEP or the TB program remains a vertical entity in the health system, and the other general health system staff are not responsible for that work. The program considers all the health system staff as NTEP staff because it is a part of their job responsibilities. And now the program, with the support of the state health systems, because health is a state subject, they are trying to enhance the capacity and the involvement of the general health system staff. And there are some states that have gone far ahead in ensuring that kind of a motivation and involvement. So then one question in the open forum is the program planning to standardize the stool sample testing by NAT at peripheral lab? So Dr. Mattu, could you take this question up?
So again, for this having this stool test in the program, so basically WHO recommendation are there that this CVNet Ultra cartridges are to be used in the stool. This is WHO recommendation, and if you are using this cartridges which are available with the program, it is the MTB RIF chip is there, cartridges, and these are not giving sensitivity as it is expected. So that is not of more of use. And when we are seeing this ultra is not approved because we had a national technical expert group program wanted to get it approved, but there were certain challenges about this ultra, and there are some scanty results were coming, and because of the interpretation issue, that was not approved, and because of that, this stool sample is still a challenge. Other than this stool sample processors, the devices is another challenge. Basically, we have to have a large number of the equipment to process those stools before putting the test. So these are the two challenges. Program is considering this stool test also, but as of now, it is not in use under the programmatic setting.
Yeah, thank you, Dr. Batu. That's very clear. So there are no more questions, but there were some questions from Dr. Rituja. There's some part of her questions. I would just sum up those questions, I mean, answers to those questions, like there are increasing the registration of private practitioners on Nikshay portal. Yes, the program is going ahead with that kind of a thing. Probably you may be knowing that there is a PPSA, private, I mean, patient provider support agency system, which are reaching out to the private providers and trying to register them on Nikshay portal, and their registration is going up. And the resource provision for active counseling for adherence to treatment. What I understand from the program is that in the DRTB centers at the district level and the state level, there are provisions for counselors, but otherwise the program is trying to improve the capacity of for counseling of the general health system and the NTP staff. That's what I understand. So we stop it now. And I congratulate Dr. Matu for that excellent, exhaustive presentation and very clear responses to the questions. We will now move to the next panelist. Thank you, Dr. Matu. So now, yeah. So now, next panelist who has to speak today, unfortunately could not participate for certain reasons. So now I would now move to Dr. Rakesh. Dr. Rakesh was chairing the sessions yesterday, so I don't need to introduce Dr. Rakesh. But Dr. Rakesh is a very motivating public health expert. I know that Dr. Rakesh is a public health academician, public health practitioner, public health activist, and what would I like to call him better is a public health interventionist. The moment he finds a problem, he also finds a solution, implement it, show the way forward, and then help people to replicate those models. So my dear friend, public health interventionist, Dr. Rakesh, will now speak on the private sector engagement for the pediatric TB care. Dr. Rakesh?
Yeah, thank you, sir. So yes, I have spent a significant amount of time with them yesterday. So like again, Swati has pulled me to talk today also. So probably she has also given me a task that since Dr. Vijayashree is not there, so try to maintain the flow of the presentations. But that has actually resulted in losing all my flow in the presentations. I'll be just throwing some random thoughts today and nothing else as a part of this. Probably I'm just trying to enlarge the screen, but somehow, 1 second. Yes. I hope the screen is visible and my voice audible. I am audible.
Perfect.
Yes. Yeah.
Yes.
So what we are going to talk today is about partnership for ending TB among children. And yes, this is a statement. Our children are the rock on which our future will be built, our greatest asset as a nation. They will be the leaders of our country, the creators of our national wealth, those who care for and protect our people. Yes, they are the citizens of, they make tomorrow's India. So we need to groom them, we need to nurture them, we need to equip them with all possible means. And it's our responsibility to do in that way. But yesterday we discussed that in a day, like on a day, if you look at across the globe, around 650 children, they die due to tuberculosis. On a day, 650. And 80% of those children, they have not celebrated their 5th birthday at all. So most of the deaths happens within the first 5 years of life. And if we really look at what is causing all these deaths, we have a special habit of asking why, and we finally end up in these kind of things. There are so many things which we discussed yesterday, but if we start digging into the root causes of why this pediatric TB, why these deaths are happening, or why their children are getting tuberculosis, you'll finally end up in issues like this. Maybe undernutrition is something. The political context, like say, for example, governance systems, the social protection. I'm talking about any country. This is the scenario in any countries that will actually determine the pediatric tuberculosis there also, including the land reforms, the education systems. These are the political context. Maybe the socioeconomic status like poverty, income, education, occupations, overcrowding, poor housing, and indoor air pollutions. The substance abuse or the behavioral factors like the parents' tobacco use or harmful use of alcohol, and health system factors includes the availability, accessibility, and affordability. So these are basically the factors which determine the pediatric tuberculosis in a place. And we all know that if you look at the global TB report, it has clearly stated that the TB cases attributed to some important risk factors in India. These are the data for India given in the global TB report, which says most of the TB cases in India are attributed to undernutrition. It's attributed to undernourishment. This is as a whole. If you look at children alone, this contribution might be huge. This contribution might be huge. So nobody has attempted that because pediatric TB is, it's a neglected public health problem that the young scientists here are actually trying to look into. So my request is please do that. Please do the population attributable risk factors for pediatric tuberculosis and try to find out which are the factors determining tuberculosis in our country at least, or in the various sub-regions. But still undernourishment, it is actually remaining as a significant cause for pediatric tuberculosis. Recent data which Dr. Matu has also showed us from the NFHS survey shows that 1 in 3 children under 5 years of age, they are actually underweight or stunted in our country still now. Still, if you look at now, this is the data from the NFHS 5 survey. There are significant improvements that are happening, but still 1 in 3 child is remaining undernourished. So as a research community, we need to, or as social scientists, or as public health people, or as citizens of India, we need to ask why children are still undernourished in our country. Why children are still undernourished in our country, which is one of the root causes for all these problems. Not only for tuberculosis, but many other problems as such. This is the estimated incidence of, the age and gender distribution. These are in actual numbers, basically. The gray thing is the estimated incidence, and what we are seeing in the other colors are like actual cases notified in the particular age group. So we could see that in India, we discussed this yesterday, 40% of the entire population. I repeat, 40% of the entire population, they are children and adolescents. It's a huge number. This is the country with large number of children and adolescents. So the numbers are huge. The numbers are huge, especially if you look at the gap of 15 to 24. The estimated incidence of tuberculosis numbers are huge. So we are talking about huge numbers. We need to look at demography also, like the age pyramid of India also like this, and see. This need to be done. Yesterday we discussed that this need to be done. The epidemiology of TB also varies across different states, even within the states. So as a research group, we may need to look in depth into various epidemiological determinants of pediatric tuberculosis in various states, various countries, the determinants and all. Further, I looked into NFHS 5 data, which are these are some of the insights which I got. Households use clean fuel for cooking. Obviously, yes, this might be coming down. This might be increasing now because of the Pradhan Mantri Ujjwala Yojana kind of setup, but still we could see that there is a significant proportion of households in the country which are still using unclean fuel for cooking. Similarly, not going into detail, but insurance, those who are having an insurance coverage, the fertility rate among adolescents is represented. Institutional births, yes, we have significant gains in institutional births and coverage of BCG, 95%. Yes, women using tobacco, men using tobacco. Yes, there are significant improvements, but look at the numbers now. As of now, again, 38% of the people, adults who interviewed, are still using tobacco products. So these are some of the determinants that is not only affecting the pediatric tuberculosis, but many other health conditions that is affecting the children as such. So as researchers, again, we need to work on finding out solutions. Not only if you really are planning to end tuberculosis among the children, we need to start from here also. That's something which I will try to convey. Yes, there are many inter and interstate disparities in the child survival that we could actually observe. ranging from, if you just look at one indicator of under 5 mortality, it ranges from 10 per 1,000 live births to 56 per 1,000 live births in India. So that means not all our children are getting equal opportunity for survival. They're not getting equal opportunity to live, basically. So this is something which is more worrying. So we need to ensure that all our children are getting equal opportunities. So we need to make it equitable also for children to survive. These kind of subnational data are actually, especially focusing on pediatric tuberculosis, are something which the researchers can actually try and look into. Subnational data estimations for pediatric tuberculosis and how it actually looks like. And definitely, yes, if you are trying to intervene, we need to follow a life cycle approach. Definitely, if you're trying to intervene into, I'm sure that Dr. Devadasan will be discussing all these things in detail when we are looking at the systems approach. This is something which has actually attracted me to this group, because we are actually trying to look at the systems perspective and policy lens towards solving such kind of issues. So definitely, yes, we need environmental interventions, nutrition interventions, and health interventions. There are lots of programs which Dr. Mattu has already explained that government is actually running, and we need there are multiple opportunities provided through these programs. The partnership starts from here. While we need to engage with the private sector, the most important thing that need to happen is partnerships need to start within the sector itself. So various ministries, various programs for child survival like Anemia Book Bharat or RMNCHA, the immunization program, the NSSK, the RBSK, the aspirational district program, Ayushman Bharat Health and Wellness Centers, Poshan Abhiyan, all these things need to work collectively. So there need to be a strong integrated mechanisms in place, partnership in place to ensure that finally we achieve the goal of improvement in the child survival within the country. So this is the direction in which we actually want to. So I'm just setting my context right before starting, before talking next few slides. The context is basically what we realize is that most of the challenges are social and managerial. And large gains are achievable when interventions reach the people who are really in need. So we just need to focus on whether interventions are reaching them or not. Or we need to design something which we can help in reaching those particular who are actually in need. Inequity we talked about. Local actions are really important. Local plannings are also really important. One size shoe doesn't fit all. So we may need to customize and plan and look at the local epidemiology, look at the local factors and plan locally. Then only things will be improving. We need to focus on addressing the root causes also, and we need to make the systems accountable. Make the systems accountable. This is something which we can actually, this will definitely result, this will definitely give us good results. Multi-sectoral actions are actually required, including all sectors. Everybody has a role to play as far as ending tuberculosis among children are concerned. Everybody has a role to play in this matter. So we need multi-sectoral actions. Few examples I have already provided. So when we think of partnerships, we need to think in these dimensions. Basically, if you look at, it's not only about diagnosing a case of TB, it's not only about treating a case of pediatric tuberculosis, but we need to think of the children and the entire root causes, the entire, from the system point of view, from the policy point of view, from the social angle, because TB is not only a medical disease, it is a developmental agenda. So elimination of tuberculosis or ending TB in children, it's not a medical thing. It's actually a developmental agenda. Because the moment we think of TB-free India, it also means malnutrition-free India. It also means poverty-free India. It also means all citizens in India are having good housing conditions. It also means tobacco-free India. It also means harmful use of alcohol-free India. It also means all diabetic people are getting good treatment. It also means tribal slum dwellers are having universal access to healthcare. It also means our migrants are having universal access to healthcare. It has lots of dimensions when we talk about TB-free. And so that's a developmental agenda of the nation, basically. When we think about private health sector, I'm just trying to clarify a few concepts. After that, I'm sure that Dr. Pranati will be talking to you in detail about private sector engagement and all. But the concept is, what is private? What is private? This is something which we really don't have a, many people will struggle getting a definition of what is private. There are operational definitions which talks about anything other than government is a private. Anything not owned or controlled by government is a private. Fine, that's fine. That's fine. Okay, fine. But what is the motive of private? Private sector can have motives for profit, and there are not for profit sectors also. For example, if you look at NGOs or faith-based organizations who are working, they are also not controlled by the government, but they are also labeled as private. If you are following the operational definition of the first operational definition, they are private. If you look at the training, there are formally trained providers like pharmacists, doctors, nurses, modern medicine practitioners, but there are informally trained providers also, like traditional healers. There are many people who practice traditional medicines. So they are also private. If you follow this definition, they are also private. So what I am trying to say is, from the program point of view, if you try to define private, these are all private. Anything other than government is private. From a patient's point of view, if you are looking at what is private for a patient or for a citizen, everything is private because he or she is coming for a private need. Whether they are approaching for a government need, they are coming for a private need. And if you look at the health sector related private sector, it's huge. It's saying there are service delivery providers. This is what we are focused on. We discussed about clinics, diagnostic centers, traditional healers, pharmacies, informal practitioners. They are directly providing services. But there is other private sector also, like manufacturers, supply chain equipment, supply chain property, the pharmaceutical companies, the institutions, the global health donors. So there are other private also outside this. The issue which we are talking now is about the service delivery providers. This is something which generally we talk as private providers. But if you're thinking in the broad angle of a public-private partnerships, we need to think of all these players. And not only health alone cannot manage the developmental agenda. So we may need to think beyond even health when we are thinking of a partnership options. The public-private partnerships, generally we try to explain that, okay, 40% of the people go to public and 60% go to private sector. But if you generally look at the people, how they are moving, this is not right. This is not right. What people generally does is, if a child is having some symptoms, they may initially go and consult a traditional healer, they may go to a chemist, then they may go to a government practitioner, then they go to a private practitioner also. So people will be moving between sectors. If you generally look at, there is nothing like people who are, these are not two compartments. So people will be moving to both to private and public, they may move in between. So nobody has really attempted to find out how people move. So this is actually important. So when we think of public-private partnerships, or when we are thinking of private, we are only thinking sitting at one place and we are thinking, visualizing, try to see how this is happening. But if you generally look at how people move, because our objective is something different. Our objective is to find all cases. Our objective is to treat all cases. Then we need to really look at how these peoples are actually moving. How are they seeking healthcare? Basically, they may be going to, this is something which as a social scientist, we really need to look into. They may be going to different places. They may be going to multiple providers before coming to a proper trained formal healthcare provider. And these are all opportunities for, for our actions, basically. If your intention is to minimize the delay and early case finding, we may need to intervene in all these sectors. And ultimately, there is no mycobacterium tuberculosis private, there is no mycobacterium tuberculosis public. So everything, there is only one mycobacterium tuberculosis. And similarly, there is no, say, for example, if you look at, there is no separate government for private sector, there is no separate government for the public sector. There is no separate state TB officer for private sector. There is no separate state TB officer for the public sector. There is only one state TB officer. There is one ASHA. There is one Panchayat president. There is one chief minister. There is one prime minister. There is one STO. There is one Sanjay Kumar Mattu for both public sector and private sector in India, if you generally look at. We commonly have some myths as far as private sector is generally concerned. People think that private is always for profit and we need not help them enhancing profit through partnerships. Hello, this is wrong. The partnership is neither for the private profit nor for the public profit. It is for the children. It is for ending TB in the children, or it is for ending TB in the country. The partnership's objective is not to help private. Its objective is not to help the public. The objective is to help the society. This is something which we need to clearly understand. Costly tests and drugs should not be given to the private. This is what some people actually feel. Hello, come on, this is also wrong. The drugs and the cartridges, the test, whatever it is being procured by the government of India for its citizens. So its citizens. So somehow we need to reach the citizens, either through the public sector or through the private sector or through some other means. It is for the citizens. One typical example with us is how we achieved 95% BCG vaccine coverage, or how we achieved good coverage in the universal immunization program. Because the government started providing, I mean, the private sector also contributed to it. They realized that there is a role for private sector need to play, and the public sector, they started providing vaccines in the private hospitals in the initial days, and they started giving it to the children. Again, we are providing vaccines not to the private hospitals, but it is for the children coming there. So these are some of the things that we need to think about. And also generally look at people coming to the private are not rich. They are not generally rich. If you ask reasons why you are going to a private hospitals, why you are going to a private provider, there may be 100 reasons which they could actually say. And you just think about it, what are the reasons which they are going to tell about. Partnerships, there are formal definitions for partnerships. I repeat, I'm just trying to explain few concepts and I will stop my presentations. Let rest of the things Dr. Pranati will be taking us through. So there are definitions for partnerships, but generally how I envision partnerships is like the public and the private, they join their hands together for the betterment of the children. For the pediatric TB is concerned, it's for the betterment of the children. They can join hands in whatever way they want. And ultimately our objective, I described about the broader objective. We need to implement that in the broader objective, starting from the prevention, in the life cycle approach, in the systems approach, addressing the determinants. But for our easier understanding, I will just explain one thing. So you can take up these lessons and try implementing it in different situations, addressing different problems. So this is basically what is known as the standards of TB care in India, which says that any citizen in India should receive. These are the benchmark that has been decided. This has been formulated by multiple people, all stakeholders, clinicians, patient groups, patient advocates, professional organizations, public sector, private sector. They all sat together and said, okay, fine. These are the minimum set of standards that every citizen in India should receive as far as TB is concerned. And the vision of the program is also like people suffering from TB receive highest standard of care and support from the healthcare providers of their choice. This is something the program is also trying to keeping it as the vision. So standards of TB care in India is equivalent to the quality of care as far as TB is concerned. So we are all working towards increasing the quality of care to the children. So there are definite standards which has been mentioned. So this is again another area which we can look into. Are all our citizens receiving the standards of TB care in the country? There are various steps for establishing partnerships, which again, I don't want to get into the details. Maybe starting from mapping, starting from sensitizations, trainings, engaging them, all this sort of stuff. But I'll just take one example. So we may need to engage with hospitals, we need to engage with the individual practitioners, we need to engage with the chemists, we need to engage with the laboratories, we need to engage with the informal providers also, if you are really trying for a private sector or public-private partnerships or private sector engagement, whatever it is. But I'll just try to explain just one scenario, and rest of the things I am leaving to you to conceptualize, think, study, understand, develop, and implement and improve the well-being of the children. So one such approach, which one of the states have attempted is basically, it's called System for TB Elimination in Private Sector. It's called STEPS, S-T-E-P-S, STEPS. It's called System for TB Elimination in Private Sector. So they established a system. So that's something which we really need. There are 4 pillars in the National Strategy Plan. Yesterday, somebody was asking whether detect is important or treat is important, right? So there are 4 pillars under National Strategy Plan: detect, treat, prevent, and build. So detection means we need to detect all cases early and completely. Treatment means we need to detect all cases. We need to treat all cases correctly and completely. Prevention means somehow we need to prevent getting TB infection, also from breakdown of infection to the disease. These are all prevent. But what is build? Build is something which is equivalent to system strengthening or building systems in place. So what I suggest to the program managers is you just focus on the build. Focus on the build so that automatically detect, treat, prevent, all these things will automatically happen. This is one such build component that has been done by the private sector, initiated by the private sector, led by the private sector in the country. It's called STEPS, and it has 3 components. One is basically a coalition of professional medical associations. So they have formed a coalition of professional medical associations with all professional associations, including IMA, IAP, Orthopedicians Association, Gynecologists Associations, Radiologists Associations. All these people, they came forward and they formed a coalition of professional medical associations. And they advocated with all the doctors to follow standards of TB care in India. Standards of TB care in India. They also formed a private hospital consortium at district levels. So that includes owners of the hospital, the private hospital managements. So big managing directors, they are mostly non-medical people also, but they formed the consortium. And they basically advocated for establishing steps. They provide all policy support to the private hospitals, and they just review the performance of the private hospitals also. So it was reviewed by the private hospital consortiums. And third component is a step center. Step centers are the centers within a hospital where it acts as a single window mechanisms to ensure that all the citizens reaching that particular hospitals will receive entire standards of TB care. Again, standards of TB care is equivalent to the quality as far as TB is concerned. So the private sector, they came forward. So and they said that, okay, fine, it is our responsibility to ensure that all the clients reaching us are receiving standards of TB care. And this is what they call as steps. So this is a private-led model, basically, and it has been launched by Dr. Soumya Swaminathan. This is the health secretary of that particular state. This is the private hospital consortium chairman. This is the professional coalition association leader at that time. So they all came together and said, okay, this is something known as steps. And that started as a movement. And finally, what we have seen is most of the hospitals, around 400 hospitals, major hospitals in that particular area, joined this movement, this private-led movement, and they all pledged themselves to say that, okay, fine, we as a member of consortium of private health facilities for TB-free district, we are committed to ensure uniform high standards of TB prevention, diagnosis, treatment, and public health services to all those who seek with us. See the commitment of the private hospitals, right? So this is how they actually came forward. And what they did inside the hospital is they just created a single window mechanisms and they provided all forms of guidance, support, linkages to the patients. What they tried is they tried to follow an after-sales service model. After-sales service model is something which means like once we sell a car, we used to receive a call from the call center. They actually asking about how are you, is the service okay? So this is basically trying to foster the customer loyalty. What the private hospitals did is basically they actually the nurse or the PRO, the dedicated steps lead in each hospital, they followed up each of their patients. Every patient they regularly, meticulously followed up. They established a good rapport with the patients, and they actually inquired with them, are you okay? Have you taken the drugs today? Do you have any adverse events? Your next appointment is scheduled on this date. When you are coming, just come and meet me directly so that I will help you bypass the queue so that, your time is also saved. The airborne infection control is also ensured. And finally, at the end of this thing, the patient is happy, the private provider is happy, the private hospital is happy, the public sector is happy, and the society is also happy. So previously, in some of the hospitals, when they initially started, before starting such kind of initiatives, 60% of their patients were completing the treatment. This is what their data has actually shown. But after they started proactively following up their patients, and that figure has gone to almost more than 90%. So now 90% of their people who are reaching them, the clients reaching the private sector, they complete their treatment successfully now through initiatives led by the private sector by fostering the customer loyalty. Obviously, yes, nurses played a major role. Most of the private sector initiatives were initially tried to focus on doctors, but there are a good group of people like nurses who could play a major role, especially related to counseling, especially related to documentations, especially related to all this sort of stuff. Many of the hospitals, they have established step centers inside the hospitals. They have provided the room. They appointed their own staff, paid salary from their pocket for the benefit of their patients. Trainings were provided by the government, and some of the hospitals' drugs were provided by the government, and all sort of other support, whatever is required, government tried to provide based on whatever the private hospitals asked for. The hospitals themselves reviewed their performance. The private hospitals reviewed their performance. The team inside the hospitals, they reviewed each and every case and ensured that each and every patient received standards of TB care. The hospitals were reviewed by the private hospital consortium. The consortium is formed by the private hospital managements of a particular district. They reviewed the hospitals on a regular basis. the coalition of professional medical or associations, including IMA, IAP, all these forms of doctors, they met regularly and they all pledged that, okay, fine, let us do our best to make the city TB free. As a summary of the steps, it relies on the social responsibility of the private sector. Plus, there are profitable customer care services also. It fosters customer loyalty. It helped in documented improved standards of care among the patients reaching the private sector, reducing the out-of-pocket expenditure, and strengthen the system to ensure universal access to TB care in the private sector. This is just one such model. It also has led to the steps. The system for TB elimination in the private sector has been converted to system for total engagement of the private sector, because all national programs could actually enter through the system, and it has become like grown up like a system where all national programs could actually talk with the private sector in that level. So this is something which is sustainable, private-led, for the benefits of their own, understanding the concerns of the public sector and the private sector. So similarly, we need some solutions. There is no innovations. This is just a solution, basically. The solution is because of the problems. Why partnerships were not happening? Right. They analyzed it. They found out the reasons. They built the solutions and they did it. They showed it, and it is sustainable also. Right. So this is just one such example which I try to show with the hospitals. Similarly, try to do with the laboratories, chemists, try to do with the informal providers. All these thoughts are pending. Now you are there. You can take up such kind of initiatives as implementations research, designing from end-to-end solutions, right? There is something called Schedule H1. This is Schedule H1 regulations, which is basically all anti-TB drugs need to be sold by the prescription of a modern medicine practitioner, and that need to be documented. Who has prescribed that and for whom that drug has been issued. So this has immense potential for helping in the surveillance. So maybe if you are interested, you can further look into these aspects also. I'm not going into further details of this. But my last point would be, we are thinking of public and private, but there is some other important stakeholder who is the community. The community need to be the partner. I would say a step higher, the owner, basically. The community need to be the owner of this entire process, whether it is public-private partnerships or whatever it is. The partnerships or the ownership need to relay with the community. Then only things will actually move. Then only things will actually work. We need to make it into a people's movement. That's what yesterday we have discussed. We need to convert this into a people's movement against tuberculosis. So ending tuberculosis, especially with related to children, we need to hear the voices of the children also. So there may be many adolescents who will be interested, who we need to hear their voices. Without hearing their voices, it's actually any public health interventions if you're doing, without hearing the beneficiary. I mean, I'll just narrate an example. In one of the places, they were providing nutritional kits to all tribal people. The nutritional kits to tribal people, government was providing. Huge amounts of funds were there. So they wanted to, intention was really good. They wanted to provide good sort of materials to all the tribal people. So they designed a wonderful kit consisting of costly cashew nuts. They provided basmati rice. They provided chana, dal, all these sort of good proteins, high quality proteins they put into a kit, and they started regularly giving to the tribal people there. But at the end of 2 years, they realized that none of them were actually eating. Then they really asked, why you are not eating? Somebody went and asked, like one like you went and asked, why you are not taking these kits? Then they said, we really don't know how to cook. We don't have a pressure cooker to cook. So we really don't know how to cook this chana. They said, this all looks very polished and white. We generally like something very black and brown because that's what we actually eat, the tribal people. Most of these are like something like cereals, but we like roots and tubers or leaves. These are something which we generally like. Cashew nuts, we really don't know what these are actually, whether it is good for consumption or not. So these are the damages that can happen if you are not taking the community, if we are planning for the community without involving them. So what are interventions you are planning? Take the community with you, make them plan, make them do, make them execute. You just play the role of a facilitator, make them be the owners. The last initiative which I want to tell is about the thing which I mentioned yesterday, the TB-free air for every child. Yes, this has been taken up by an IAP chapter. IAP is Indian Academy of Pediatricians. Kerala chapter, they were actually trying to provide a theme called protecting child rights. And they realized that, okay, fine, there is nobody else to talk for children. So let us talk for children. And they said TB-free air, breathing TB-free air is one of the rights of every child. And they started fighting for it. They said our children are actually getting infected because there are many adult cases in the community. They started saying that we need to ensure that our children are having TB-free air. So it's an advocacy campaign initiated by the IAP that has actually resulted in the rollout of many initiatives, including TPT in the country, much ahead of the national programs. But I am saying this kind of initiatives also we require. The two things which is actually missing from the public health textbooks are, one is advocacy. Advocacy is something which is missing from the public health textbooks. That's what I feel. So we all need to be, researchers need to be good advocates. Without advocacy, research has no value. Research is for finding a solution and solving that problem. So without advocacy, research has no value. So that is something which we need to find out. Second thing is accountability. Accountability is something as a research community, we have accountability and we need to ensure that all others have accountability. Let's dream of a world where all our children will get an opportunity to breathe air free of Mycobacterium tuberculosis. And thank you so much.
Hi, thank you, Dr. Rakesh, for that very energetic, passionate, and motivating presentation. So we have some time for questions. I think we have 5 to 6 minutes to get some questions. Let me ask one question. Anyway, you have highlighted one thing very, very clearly, that is ending TB is not it's not a health agenda, it's a developmental agenda. Good take home. You also have highlighted about some myths that has to be really demystified. That's about the program. The national programs are partnering with the private sector to increase their profit. That's a myth. I don't think profit is a sin, but still programs are not partnering with the private sector for increasing the profit of the private sector. And then profit is, of course, a byproduct of that entrepreneurship. Then you also have put some light on, thrown some light on the myth on how costly public provisions cannot be shared with the private providers. And you have given examples where private provisions have actually been shared. So I think the public X-rays, the public gene expert machines, and all such sort of public provisions could easily be shared with the private providers for the benefits of the people who are seeking care from the private sector. The third myth you were speaking about was the people who are going to the private sector. People are going to the private sector because they are affluent. We know TB is a poor man's disease. At least in India, we have seen that 70% of the people are almost having a very, very low income. And 70% of all TB patients are going to the private sector. That means the poor people affected by TB are going to the private sector. It's not because they are affluent. So thanks for highlighting these issues. But I have a question. The question is, it's maybe very, very, very precise, very basic, but you have highlighted that the engagement with or partnership with the pharmacists, the chemists, and the less than qualified providers are also important. So do you think that in the context of pediatric TB, the partnership with chemists and less than qualified providers or informal providers is important?
Definitely, yes. There is no doubt in that. I mean, if you generally look at the children's pathway, if you look at, most of the rural areas, if you look at, if somebody develops cough, fever, or whatever it is, the primary point of contact, if you look at the place where they go first, most of the places, it will be a rural provider or a chemist. Most of the places. I mean, we are talking about in some of the places, say, for example, states like West Bengal or some other states, if you look at, there are they outnumber the number of qualified practitioners also. I'm saying the first point of contact for any disease in most of the areas, that's what something which we really need to document. They are chemists or less than qualified practitioners. So probably if you're talking about for ending tuberculosis, not only for children, but for the adults also, like we know that the children are getting disease from an adult. So if the adults are actually coughing for a longer time, for 3 months or 4 months, all children in their household will get the TB infection. They will get the disease, right? In these 4 months, the adult might have gone to 10 chemist shop, maybe for getting the cough syrup, right? They might have gone to some informal providers for getting some sorts of treatment. Any of these 10 points, we could have actually identified TB in this adult if we would have engaged with the chemist or a private sector. We'd have prevented the child getting TB in the household by detecting them early. So if you are asking me, is that important? I say that that is the most important crucial step which the country need to do. If we are really planning to cut down the transmission, we need to somehow map the patient pathway, identify their seeking behaviors, get in touch with the chemist or the informal providers, engage them. The engagement could be in different ways. Our ultimate objective is to get early diagnosis, right? We can acknowledge them. We can actually appreciate them. For example, one recent initiatives which I have seen is chemists are engaged, they were trained, they understood why they are doing that, and whoever is coming to get a cough syrup from them, they give a pamphlet regarding TB IEC materials, and they say that, okay, this is this gluten cup, you can collect the sample, and you can either leave it here by filling this form, or you can give it to the next laboratory there. So this actually helps in early identification of tuberculosis, at least by, if you could cut down the mean delay, at least by 1 month, that's a wonderful thing that we can actually do. That's the answer, sir.
Thank you so much, Dr. Agish. I also tend to agree with you that engaging the informal providers, including the chemists, is going to be the next important agenda, has to be the next important agenda for the program, because traditional healers and other informal providers and the chemists are the next door healers anybody would access immediately for their health needs. Thank you for that. Now we open this up for questions from the floor. Do we have any hands raised?
Can I?
Yeah, please go ahead.
The fact that what Dr. Rakesh told, that the patient goes through public and private, it's not like separate, that actually pulled us to reality. Like many a times when we are thinking, we say it as private patients and government sector patients, but it's not actually so. They go through a whole pathway before actually reaching the final care point. So in that front, again, Shibu sir asked about that, the engagement of pharmacies. Even our local data, we have a 20-year-old HDSS running in KEM site. So we collect periodic census. So in that, in the latest census, which is ongoing right now, so the data till now shows that almost 10% of the pediatric care seeking happens in the pharmacies. They are the first points of contact. So in that front, the pharmacy engagement really becomes important, especially in rural areas. So I just wanted to share the data from our site regarding that.
Thanks so much. That's very important. And it's very encouraging to see that such data is available from different parts of the country from the researchers. I would also encourage people to look into, usually we speak about the care-seeking behavior of the patients. That's a fancy word we always speak about. Do you have any insight on the patient-seeking behavior of the healthcare system? So is it important to achieve any of these national and global goals on ending some of the communicable and at least modifying the non-communicable diseases? So let us think it later. Thank you so much, Dr. Rakesh. I don't see any questions here in the chat or in the question answer, but yeah, we have some questions. Remind us about having the presentations on having the presentations. Yes, Dr. Rutuja, you have responded to that one. Yes, these presentations will be available to all the participants in the link share. Right. So we'll now move to the next panelist. The important, this is a continuum, is engagement or partnership with the private providers who are very important, very crucial in ending TB and similar communicable diseases and addressing some of the issues due to the non-communicable diseases. So we have Dr. Pranati Das to be a part of that continuum. And we will, Dr. Pranati Das is now working with the Clinton Health Access Initiatives. She has a great lot of experience in engaging with the private care providers. So I had an opportunity to meet her during her field visits and to understand how she looks forward to having partnerships with not only the programs and multiple private sector leaders. And she is now leading the Project JEET, joint effort to eliminate tuberculosis. Now JEET is implementing the TB preventive treatment across 11 states in India. So she's a doctor in biotechnology and 15 years of experience in public health and research, working for interventions in visceral leishmaniasis, diarrhea, maternal and child health, and tuberculosis. She has been actively engaged with private sector engagement for TB through her contributions in the PPIA PATNA pilot. The public-private interface agency has been piloted in 3 districts, and Patna has been 1 district, and that has led to breakthrough events and having the PPSA model in India, which many countries are now looking forward to. And she is now supporting JEET and leading public-private partnership in India. So thank you, Dr. Pranati, for being with us. Over to you for your presentation.
Thank you, sir, for your very kind introduction. I think before I begin, I would really like to thank the organizers and the session moderators. I think this is really, really honoring. And so I mostly was asked to talk about engagement of the private sector providers for pediatric TB, mostly to share my experience from the PPIA and the PPSA work, and also lately supporting the state of Bihar in contracting the domestically funded PPSAs and managing those contracts for successful implementation. So I'll just take a moment to share my screen. Let me know, sir, if it's visible. Sorry, if I may, if I may just turn down my video because I don't think I have a great.
Please.
Sure, thank you. Yeah, so I think over my talk for the next 20 minutes or so, what I'll try to do is have a set a brief background about the adaptations within the national program and policies for creating a more enabling environment for welcoming private partnerships in the overall TB program. Some of the major implementation projects, we have heard about one of them a while back when Dr. Rakesh sir was presenting. Try to bring in some learnings as to what has worked well in engaging effectively with private sector providers. Also talk about some potential barriers when it comes to engaging them for pediatric TB. And then towards the end, I would like to share some of the ideas, some of my thoughts around how there's scope for more research to build a stronger evidence for further policy planning and intervention designs. So over the last about 10 to 12 years, as we've all seen, the National TB Program has evolved significantly with respect to identifying the private healthcare sector as an equal partner in managing the TB burden in the country. And there have been adaptations into guidelines and policies to make this more conducive and enabling for a better engagement with the private sector. So the notification gazette that came out in 2012 made it mandatory for all healthcare institutions, whether public or private, to notify all patients diagnosed. And then the follow-up gazette in 2018 indicated the legal implications, not only for providers who are diagnosing but may not be notifying TB, but also for the public sector program team for failing, if they fail to provide the rightful public health action to all notified patients, regardless of whether they were seeking care from a public or a private healthcare facility, once they were diagnosed and initiated on treatment. We also had these standards for TB care in India released in 2014. It acknowledged clinical diagnosis, which is primarily true for a majority of private sector TB, patients who get diagnosed in the private sector. And so that was acknowledged, and they were they would have to notify even those cases which are not microbiologically confirmed, but have a more clinical and supported radiological evidence for diagnosis. Then there was adoption of the daily regime and the fixed dose combinations coming into, under the program. And this sort of, helped bridge that gap between how the private sector and the public sector were treating the patients of TB. So that really helped welcoming, to the providers to join hands with the national program and report their patients, and also link them with the national program and all the public health benefits that are available for patients. Then, in terms of the different support schemes, we had Nikshay Poshan Yojana, and also the notification and outcome reporting incentives for providers that were, that came into being from 2018 onwards. And then there was this guidance on partnerships, the PPM guideline document that CTD released in 2019. And very recently, we had more supportive, guidance documents around how to operationalize PPSAs, how to go about contracting, talking of EMDs, the entire QCBS process, so on and so forth. So then we see a lot of, advancements and, how the program has evolved and how it's very, very evident and, very strongly coming forth that the program is really keen on engaging with the private sector. And why I'm mentioning this, because, it has helped us in pitching the providers, the private providers that we have approached through our projects on how the national program is actually looking up to them to participate and join hands and contribute to the TB care program in the country. So over this period of time, the country saw several donor-supported pilots and implementation projects, and they all, I'll not go into the details of all of these, but then all these projects adopted various approaches and models for private, engaging with the private sector healthcare providers. I think I'll skip most of the earlier ones, but domestic PPSAs I would take a moment and talk about, because somehow the evidence that was created as part of these projects and the pilots and implementation projects running across different parts of the country actually led to adoption of what we call the PPSAs, or private provider support agencies, to be put up into PIPs of the states and to be funded domestically, which definitely answers for a more sustained model of engagement with the private sector. As of last year, we had 385 districts across the country, primarily over 22 states, have an approved, have an approval for contracting PPSAs, and 188 have been successfully contracted and are being implemented more in line, in various stages of the RFP process. So I would like to take a moment and talk about some of the key tenets of these domestic PPSAs, which form key determinants, that drive their operations on ground. So these, and why I'm taking a moment, because some of, how how the pediatric TB care service may be brought to more focus, may actually have to go through some of these details. So these PPSA contracts are output-based contracts. That's coming to the, towards the later part of the slide here. These are output-based contracts, which essentially means that the payments are made once the desired defined results are met. And this requires laying down very clearly defined scope of work for these agencies, a well-defined performance indicator framework with targets and timelines for each, And then payment matrices are diligently defined, with key payment linked indicators, benchmark, targets, rules for payment, as well as rules for penalties and adjustments in case of underperformance. So overall, these performance and payment matrices are what largely guide, where and how the on-field efforts and energy, the approaches and strategies that these agencies adopt is led to a great extent by these performance and payment matrices, so that they can maximize outputs and hence their payments can be. So that's been the learning from the last couple of years of supporting the domestic PPSA contracts across some of the states. Now, next, coming to this slide, where what I've tried to do is, not go into details of the models of each of these different PPSAs, be it domestic or earlier donor-funded projects. But then what's really interesting is, there are some unique common threads that form the essence of ensuring a strong partnership with the private sector providers. So first is retention of clients. I think retention of patients with the same providers throughout their course of treatment and care. That stands out as almost a non-negotiable factor. We have seen very, very few providers who are open to making referral of their patients, referring their patients in entirety to a public sector health facility for any service delivery and care. So that's been, I think, one of the key elements of all the designs, of all the models that we've seen, that the patient usually remains with the same provider, and whatever services are to be offered to the patients is delivered primarily through the same provider facility or a nearby but a public a private healthcare facility itself. Now, the next important thing has been how it's important to offer some quality services to the patients. So, the usual question that we've been asked, our field teams have been asked when they go and pitch a provider on why it's important to join hands with the national program to notify their patients, is what is it that my patients benefit out of this? Or how can I ensure a better service delivery to my patient? What do you bring to table in those regards? And one of the things which has really helped to, sort of foster this strong partnership is how there could be linkages for diagnostics, primarily speaking of the gene expert, CBNAT testing, which almost 10, 12 years back, it wasn't very known to the private sector. Not many doctors were prescribing it. Diagnosis used to be mostly primarily based on chest x-rays and some other supportive tests. So when this test, which which the providers understood is a molecular diagnostic test with a high sensitivity, specificity, being very costly in the private sector, but when these projects or programs bring it to their doorstep for their patients free of cost, they saw value in this. And that's how, this became one of the hooks, initial hooks to engage and gather interest of the provider to engage, because there was this important service being brought to their, the doorstep literally. And that also required setting up convenient sample collection and transportation mechanisms in place, where patients would not have to wander from one facility to the other, but they could just, deposit their samples at the facility that they went to seek initial care. And then whether it's the PPSA or any other model, they would support collection and transportation of these samples to the nearby designated lab and get the test reports back to the facility where the patients could access it. And the doctors could kind of make interpretations and do the needful prescription further. Other than CBNAT, I think having the NTP FTCs made available to the private sector patients free of cost has been another very important hook, if I may say that. the intermittent regime was something which most of the private sector providers had not taken very well, and they had mostly been prescribing a daily regimen even prior to adoption of daily regimen under the program per se. And when these drugs were they were brought in, and moreover, there was an effort to make sure that these drugs are made available to private sector patients on their own doctors' prescriptions. And again, there were different models which were different components of the model. Some of them being that these drugs were made available at the health facility itself or at a pharmacy nearby the health facility, where the patients of that doctor would usually walk up with their prescriptions to get treatment, to get the drugs. So that again, what it made possible was that the patients did not have to change the pathway that they usually would have with the doctor, but then these services, standard quality, free of cost services in the form of diagnostics and drugs were made available to them. So that helped a great deal, and that's actually being common across all the different models that we have seen and we are currently also seeing in the country. The third important element was offering a structured treatment, monitoring, and adherence support mechanism. Because as it was, and maybe is likely to be the case with facilities that are not really engaged with such a program, the private sector doctors have usually a weak system for continued tracking of their patients. They would hardly call back a patient if suppose they have not turned up for a scheduled consultation. Or hardly anybody from a private sector facility ever calls a patient if they have been taking their medicines as prescribed with the same dosage and frequency and all that. So that again, when most of these projects, what they ensure is that the patients that are in the care of the private provider are provided a very close, a very robust monitoring and adherence support, so that there is early identification of anybody who may be tending to stop treatment midway. Also attend to people who may be experiencing some side effects, adverse drug reactions, and bring them to care, and not really have leave them to default, right? So that has been a great important element there. Then what we have learned is it's important to keep this engagement very, very documentation light, because not all doctors will have staff, and not many are willing to actually engage their staff with a lot of documentation. So the minimal we keep the documentation, the better it is, or the better acceptance there is for that. And in some of the models, we also see there are HR support, people who will support the health facility to the needful documentation. So that's also a part of some of these models. The other two that I have up on the screen, I would say are not really the initial enablers to engage, but definitely are important when it comes to sustaining those engagements. And that's on the incentives, as I was earlier mentioning. The program offers incentives for notification and for outcome reporting. So if these are promised to the providers, they better be paid in time, because otherwise it becomes just one complaint coming from the doctor, and it doesn't really serve well for a strong partnership. We've also realized that some non-financial incentives, primarily in the form of recognition of some sort, or where they can be, say, made a panelist in a panel discussion, or maybe brought in as KOLs for some CME sessions, where they feel that their experience and their knowledge is being looked up to, and then there are doctors in their in the peer community that they can talk to and share their experiences, and also mobilize them to come into the fold of this and start notifying patients, or treating their patients with these support services and all. So with all of these, it has what has this led to? So I've just tried to put in this few numbers from our India TB reports, comparing how it has fared in the last 5 years. So if you look at the private sector contribution to the total TB notification in the country as it was in 2017, so the private sector contributed to about 19% of total notifications, whereas 5 years hence, it rose up to 30%. And a lot of this has happened because of the varied interventions that we just sort of alluded to. But in the same line, if we have a look at pediatric TB notification and how that has grown, there isn't much improvement compared to how it was, say, 5 to 7 years back from now. And it's been similar in the public as well as the private sectors. And we've seen that earlier when Dr. Mattu sir was presenting how it's almost stagnated at about 5 to 6% of the total contribution, total notification, sorry. And the pediatric TB management guidelines of the Government of India also indicate that there's about 56% detection gap in the pediatric TB cases in India. So, just thinking why, when there are so many efforts being undertaken to engage with the private sector, and there is definitely an increase in participation. We have more private sector providers now registered onto NICSHARE, more private HFIDs notifying their patients, linking their patients to, molecular diagnostics, offering more, better coverage for UDST, linking them to the NICSHARE Poshan Yojana and other schemes. But then most of it is being driven by the elderly age, by the non-pediatric age group or the adult age group, if I may say. So why is it that we continue to miss upon the pediatric TB cases here? Now, I've just tried to put together some of, basis my limited understanding and experience from field. But then we have seen over the last day's discussions and even earlier today, how it is, even difficult to identify the presentation of TB in pediatric age group, making it very difficult to, to identify a presumptive pediatric patient, screen them, and diagnose them. I mean, we've heard, I need not repeat that it's difficult to have a sputum sample from the pediatric age group, and whatever are the alternative ways of sample extraction. We've heard about gastric lavage or bronchoalveolar lavage, but all of these are very invasive. And what we realize that although there would be some providers, some private doctors who would want to take that route, but as PPSAs, we did not really have any or very limited support that we could offer for sample extraction. So very limited health facilities which would be ready to offer, that sample extraction support, even in case if a doctor or a patient parents would be willing to take that up. So that has been a big sort of roadblock there. Where do I send my patient to get that lavage done? And further to that, subsequent to that, where do I send those samples for testing? It's not only for for these samples, but mostly so for the EP samples as well, because not a lot of the public sector NAT sites were ready to take EP samples, and we understand so the pre-testing processing for these samples is a challenge, and that sort of limited us to offer this support to the provider. And hence, and just taking the next point there, that even if we could, even if they had samples, it's usually, we know that the samples from pediatric patients, the tests that are available, even NAT has a low sensitivity and specificity when it comes to pediatric samples. So, all of these taken together, it really limited how far we could offer this service to private sector providers who were dealing with, pediatric patients. The other, important felt gap was for a lot of doctors, the pediatric TB forms a very, very small part of your overall OPD. And hence, they would not be really interested in taking up all of this, extra work, as they would call it, of any documentation because for them it was a very small proportion, and they would usually have these people, they would prescribe services for diagnosis and for treatment, and these people would go ahead and take it from the private sector. So not really a big area where we could grab their attention. We could make a solid offer on what services could be offered to their patients. Moreover, even for PPSAs, given the difficulties in diagnosing cases that are pediatric, given the difficulties in engaging with these, usually the pediatricians or doctors who deal with the children are actually low priority for PPSAs, not for any other reason, but for the reason that the numbers that they have to meet, the targets that they have, are usually answered better when they go out and say engage with the general physician or a chest physician for that matter. Now, as a strategy, most of the PPSAs that they are, when they look at who are the providers in the geography that they cater, they would want to go to doctors who are notifying the most cases of TB. And unfortunately, that doesn't happen to be the group of pediatricians. So, by that design, the other doctors, or like I said, the general physicians, the chest physicians, they become the higher priority providers to engage with. So that's been one of the reasons that I've really seen across a lot of geographies. Coming to the treatment that's available. Now, not many child-friendly formulations are available, and this I'm seeing not only for TB, but even for the TB preventive treatment, as we are currently working with. Most of the doctors or parents also, whose kids are, say, under 5 or 6 years of age, would want a syrup sort of a thing, because children that age are not really very good at gulping down tablets. And we do not really have a program recommended or such formulations available under the program to be offered to them. Added to that is the challenge of high bill burdens with the FTCs that the program has. And if you noted in the presentation of Dr. Mattu sir, at a time on a given day, a child may have to gulp down 7 to 8 tablets, which is not very, very pleasant. So, coming to drugs, I think these have been the major challenges. And at the end of it, it's mostly the parents of the child. Because of these reasons, they are more unwilling to take up these drugs and would go with a private drug prescription. Some places we also saw, or initially with a lot of providers we saw, the tendency to have less trust or less confidence in what's being offered under the program. So, those have been some of our challenges and perhaps some of the roadblocks that not only us, but other teams like ours have experienced in engaging with the pediatricians. And hence, we do not see really, as high an improvement or as big an improvement in the numbers of pediatric TB notifications as has been overall for all TB cases coming from the private sector. Now, over the next few slides, I'll just, what I've tried to do is just put together some of our learnings and how maybe some of the ways in which the PPSAs maybe, so the slide talks about how the PPSAs that are currently implementing across different geographies may be leveraged to engage with pediatricians with more energy and focus. Now, one of the things, like I said, because each of these agencies have specific targets that they have to meet, and it's easier or comparatively more convenient for them to engage with the non-pediatric catering set of doctors. So just a thought, maybe having their notification targets segregated across adult and pediatric age groups might make them more inclined to, to actually go out and engage with the pediatricians. And no matter how difficult it is, to at least try and take that route so that we have better, better information, better notification coming from this age group. We heard about the MOU with the IAP at the national level, but not many states have actually translated that into action at a district, at a state and a district level. So that may, it's upon the state program teams to see how the existing PPSAs can actually use these, the agreement that is there at the national level and use it at the local level to engage these forums better and to reach out to more pediatricians. More active or intensive case finding efforts, definitely to reach, to engage with the right facilities, and even early identification of high-risk children. Children who are living with known pulmonary TB patients in their families, they are at a high risk of infection and disease maybe. Malnourished children. So, do we engage with such centers which may be dealing with malnourished children in the private sector and try and screen them, subject them to the right diagnostic tests and treat them as appropriate. Homeless, slum-dwelling populations. There are some private NGOs, and as Dr. Rakesh was mentioning, when we are talking of the private sector, it's not only the doctors or the pharmacies, but also the other, other entities that are private and maybe catering to the population, catering to the health needs of the population in some way. They need to be engaged as well if we have to really ensure covering everybody. Targeted engagement with pediatric hospitals and specialists as hubs, because a lot of time so one of the models is a hub and spoke model, where a larger health center which has, say, more specialists is made a hub, and then nearby smaller or non-specialist centers are made as spokes, where a referral system exists between the spoke to the hub. So if it's all within the private sector, there's usually more acceptance. Mostly if a doctor is seeing a patient that's pediatric age group and not very confident on diagnosing and treating them, they would agree to make a referral to a higher center in the private sector itself, where there are specialists, that are pediatricians who can take care of that child. So that sort of an engagement has worked, and there's need to maybe use that more to make sure that the children get the needful care and are covered. What it helps us is, as we have more notifications and as we have more understanding of how these children are being diagnosed and treated, the first thing is to understand what are the practices, and then maybe, if there are gaps from what the doctors are practicing and prescribing from the STCI guidelines, then comes the component of training and advocating for adoption of these standard guidelines, so that each of the beneficiaries, and as Dr. Rakesh had earlier alluded to, that everybody has a right to standard care, and all of us need to collectively ensure that they are connected or linked to the right services. Engagement to pharmacies and informal providers. Again, most of the agencies, at least their higher priority is to engage with doctors, nursing homes, hospitals, standalone clinics, and not really the informal providers and pharmacies, at least in that priority. So, but again, as we all understand, these are very, very important players when it comes to the patient pathway to care, and hence there needs to be more focus, more ask from the state TB offices to the respective PPSAs. That's an area. May I request everyone to stay on mute, please? Thank you. Now, we earlier heard in Dr. Mattusa's presentation earlier this afternoon about how various different interventions or efforts are being taken under the national program for, say, screening children, development of efficient tools. And I remember there was a discussion about this in the yesterday's session also, how some of the triaging and screening tools and algorithms are being worked upon, even scoring the level of risk and hence identifying more presumptive cases. So if those come to be adopted into the program, it would make for a viable option to try and test and hence implement in the private sector as well. Monitoring of pediatric presumptive case examination. Now, I mean, if we want to really identify why pediatric TB patients are not being diagnosed and reported, it may be important to start looking into if the presumptives are even being screened and tested. And I know there may be larger reasons beyond my understanding, but then the pediatric case examination, at least in the TB reports, do not have an age disaggregation. So, we do not even know what it is like, and hence, because that would, had we had that data set, it would help us to identify, or maybe explore the reasons for that and systematically work towards finding solutions for it. Again, monitoring of chest X-rays for TB screening among pediatricians, among pediatric age group. So chest X-ray has been recommended as a screening test for children, even in the standards of TB care in India, but we do not really see much data on how it's being used and to what extent. So that may be helpful to have for further trying to translate that learning into the private sector. Ensuring access to more sensitive and specific diagnostic tests is something which we've already been hearing a lot of times. Segregation of targets, I had already said that maybe it could help the states, the districts, and the private partners that are working to have a very concerted, focus on the pediatrician engagement. Training and reference material for healthcare workers on childhood TB. Now, I have seen a lot of stuff on the CTT's website, but unfortunately, it's not really seen on ground at a lot of places, and lesser so in the private sector. So huge scope to sort of use this up, or even try to understand why it's being not taken up. Maybe if they are looking at some more research options, research opportunities, maybe trying to understand the needs from ground, not only from the public sector healthcare workers, but also the private healthcare workers, to see what they really need in terms of their capacity building requirements to be able to screen and test and treat a pediatric patient better. We heard Matu sir also talking about how the program has undertaken a lot of efforts in engaging with other childcare service programs. It would be important to, as these efforts are maturing and evolving, to sort of, coalesce these learnings, collate these learnings, and extrapolate these to the private sector. Because there are a lot of, like I said, there are a lot of, entities in the private that may be dealing with similar priorities, and maybe a good window of reaching out to the pediatric age group of, the target age group that we're talking about today.
Excuse me, Dr. Pranati, may I request you to speed up a bit?
Sure, sir. So it's just the second last slide.
Thank you so much.
Yeah. So talking now of some of the opportunities for building more evidence, doing more studies, exploratory studies, studies around how improvement in recording or reporting systems may be maybe strengthened further to capture all cases, all details, and also I'll not read out all of the things that I've mentioned, but then a lot of scope to understand one side, the behaviors and the decision-making patterns of providers. Also understand the behaviors and the decision-making priorities, or what would enable the patients or the parents of the children to take up these services, and what would really drive them to opt for these services that are being offered from the public sector, so that there could be, and so that more feasible models and more efficient models and approaches could be designed and tried and piloted or implemented for better health outcomes. So, like I said, I won't doubt, but then understanding of pediatric TB comorbidities and how DRTB is affecting the pediatric age group, how, maybe the requirement for treatment adherence monitoring may be different, how we can use, support groups or forums, teleconsultations, a lot of things which lie out there as options, but may not have been explored to the extent that it can be it can be implemented at scale and get the desired results. So I'll stop there, and yeah, I'll be happy to take any questions.
Thanks so much, Dr. Pranati. You have very clearly highlighted how PPSA, the patient provider support agency, is contributing to the engagement with the private sector, and what are the specific roadblocks for engaging the pediatricians or to provide more pediatric TB care. I will hold the questions for a moment in the interest of time, and probably we'll come back to you once we finish the presentations of other panelists. I would request you to step back if you have time. So now we'll move on to the next panelist. The next discussion is on why do we need systems thinking to tackle the problem of pediatric TB. And this is going to be discussed by speaker, Dr. Devadasan. So Dr. N. Devadasan is a medical graduate from CMC Valley. After he completed his graduation, he, along with his wife, was actually spending 10 years serving the Adivasis of the Kudalur Nilgiris. Dr. Devadasan then joined WHO and was in charge of the communicable disease cluster, and is one of the authors of India's integrated disease surveillance program. He then resigned from WHO to start the Institute of Public Health in Bengaluru, which is very instrumental in promoting the young researchers to follow their passion in public health through research training and advocacy. Currently, IPH has more than 40 public health professionals and focuses on health system research, online courses, and a PhD program. So after 15 years of his helm of affairs in IPH as founder and director, Dr. Devadasan retired from IPH and is following his passion of teaching. So he is currently the course director of the Indian Health Policy and Systems Research Fellowship Program, leads various online courses on research methods, health systems, as well as an honorary professor at the Karnataka State Rural Development at Panchayati Raj University in Gadag. So we are fortunate to have this eminent professor, and I would hand over to you for your presentation, Dr. Devadasan.
Good evening, and thank you, Dr. Shabu, for a very kind introduction. In the interest of time, I think I'll just start moving because I think we're already a little behind. Can you, all of you all see, hear my, the screen is clear?
You are visible and very well on.
Yeah, okay, great. So basically in this next 20 minutes, I'll be talking about systems, then health systems, and then why we need to look at health systems. If we take this, since the topic today is on pediatric TB, if we look at it from a clinician's lens, usually the clinician is worried about the bacilli and whether it is drug resistance, etc., which organ it is affecting, biopsy. So that is the bandwidth of a clinician when they look at a TB patient. A public health specialist will go a little further and talk about what is the family, anybody in the family who has illness, what is the economic status, are they very poor, they can't afford the medicines, they can't afford better treatment, etc. Social status, is there pollution in the air, whatever the thing. So the public health lens is broader than the clinician's lens. And here, what I am now going to share is about having a systems lens, which is broader than the public health lens. So what is the system? System essentially is a set of elements that are connected to each other for a purpose. Now, the concept of systems and systems thinking, etc., was quite well established in engineering sciences, in management sciences. It has reached the health sciences just about 20, 30 years ago, actually. Not before that, nobody talked about health system or system thinking, etc. But people are now realizing that it is important to look at the entire health system as a whole, because problem analysis problems can be analyzed using the systems lens, and better solutions can come up using the systems lens. So there are many types of systems. Physical systems, all of us know, our computer system, our car. Computers, they are made up of the motherboard, the keyboard, the mouse, the speakers, monitor, etc., which are linked together by wire, Wi-Fi, etc. And their main purpose is to capture data, analyze data, etc. Watch movies also. A car similarly has wheels, the transmission system, the steering system, the fuel system, battery, engine. These are all different elements which are connected together in various ways, and the purpose is to take us from point A to point B. Right? So physical systems are very clear, and the advantage of physical systems is that if the elements are working and if the connections are good, 99% of the time it will achieve the purpose that it is meant to achieve. So they are very reliable. As doctors and health professionals, we know about the GI system, the urinogenital system, the CNS systems, etc. These are called biological systems. Again, the same principle. There are elements, what you call esophagus, the stomach, the colon, the liver, etc. These are all elements which are connected to for a purpose of digestion and absorption of nutrition. Again, biological systems are all quite reliable in the sense that most of them work according to what they're supposed to do, except when we get a disease. Then the third element is what is called the social system. For example, a family consisting of grandparents, parents, children, maybe a visiting uncle, aunt, etc. All of who are elements who work together, are connected together for a purpose of either being a happy family, supporting the society, productive member, etc. The same thing goes with village, let's say, or any organization. I just took hospital as the image, but it could be any organization. It could be a government office, it could be a university, etc., where there are people who are linked together for a particular purpose. Now, problem with social systems is that, or rather, I won't say problem, the characteristic of social systems is that it is made up of people. People is the core. In computers, it is the keyboard, it is the motherboard, etc., which are the core, inanimate objects. Whereas in social systems, we are talking about individuals who have a mind of their own, who think, who have opinions, who have various biases, etc. And so in social systems, you have the elements and they interact with each other, but many times the purpose is not what is expected, because the interactions between the elements are not uniform. Which is why social systems are called complex systems, because they do not produce the purpose output that we expect. And so when we tackle health systems, we need to be aware that we cannot put an input A and put on the switch of the computer and the computer will come on. If we put an input A, we may get an output B, we may get an output D. I will demonstrate this a little later in more detail. But just to be aware that our health system, which we talk about, is a social system made up of people. So this is a 2007 definition, which still holds. A health system consists of all the organizations, all the people, and all the actions whose primary purpose is to promote, restore, and maintain health. The key word here is primary purpose. We'll come to that a little but there are many things which affect health. For example, today a wildfire in Hawaii will probably affect the health of, will cause air pollution in the west coast of US and will affect the health. But then it doesn't come into the health system because the wildfire's primary purpose is not to promote health. So that is why there are certain boundaries and this thing which are, quite discussed and deliberated because many people want many more things into the system. WHO has put certain boundaries. We'll come to that again. Now, like I said, a system has elements, has connections, and has purpose. So we'll start with the purpose of a health system, which is to improve the health status of the population. So that is the stated purpose. And then what are the elements? Of course, the health services, your PHCs, hospitals, medical colleges, preventive care, TB, malaria programs, the private practitioner, the village less than qualified doctor, whatever. So all of these are people who provide health services and health care. So that is one fundamental element in the health system. But there are many other elements also. For example, there's entire human resources, your doctors, nurses, then the lab technicians, pharmacists, etc. All this form another element, a key element, because they behave in a particular way. Then, of course, medicines, the supply chain, all this is also one element of the health system. Financing, money. You need money to pay the salaries for the doctors and nurses. You need money for buying the medicines, for the equipment and maintenance of the. And then, of course, you need to have policies, the governance, the leadership, equipment, and information. So, as you can see, about 7-8 elements are there in what we consider a health system. So I just want you all to take this in the thing. The purpose of the health system is to promote, improve the health of the population, and the system has these elements: human resources, health services, medicines, etc., all of which are connected to improve the health of the population. And so how are they connected? So we start with the delivery of health services, which we said, which is usually to the community. So many people say community is also part of the health system, has to be part. WHO, in its own wisdom, did not put community in the original frameworks, but later now they accept that community is part of the health system. And if you deliver accessible, affordable, quality healthcare services, the assumption is that you will have improved health status. But for that, you need certain resources, which are your human resources, infrastructure, medicines, health financing, information systems, equipment, etc. And you see that these are all interconnected to each other. So if you don't have medicines, there's not much that services that the doctors or nurses can provide. You have the medicines, but if there are no doctors, then the medicines are not going to be of any use. You don't have an information system. You do not know how much money is required for the health services, how much medicines to indent, how many doctors are vacant or nurses are vacant, etc. So all these things are required, and they are all interrelated, which then produce the health services for the community, which in turn is supposed to improve the health status of the population. There's one more element, which is your governance, which is leadership, making policies, making guidelines, ensuring accountability, etc. So usually governance we see in a health system is done either by the government or senior management in a private establishment. But there are additional things which unfortunately WHO does not talk about, but also the fact of values. The health system should be promoting values of equity, participation, social justice, and should be aware of the international, national, and local context. For example, there was a time when HIV broke out in our, when there was a whole thing of HIV. There was tremendous pressure on India international pressure to start an HIV control program. But at that point in time, we were in denial. And so we refused to accept it. But because of the international pressure, finally, we started the NACO. So that was the thing. A recent example is, of course, the COVID, when the WHO said lockdown without doing an analysis to see whether we really needed a lockdown or not. And there was a national level decision, and we had lockdown, and we all know what happened after that. So these are the contexts which affect a health system. Again, quickly, what a health system is not. A health system is not just about health services. It is about health services, but also about human resources, also about financing, etc. Many times people use the word health system interchangeably with government health services. Oh, the health system does not work. So the private sector has to come in. Remember, a health system includes the government health services, but also the private, the not-for-profit, the formal, the informal, everything is part of the health system. Now, so far we talked about the system and we talked about the health system. Now, I'm coming into the thing of why do we need a health system? Why do we need to look, understand or look at a problem with a health system? One is to diagnose and correct implementation problems. So at the hospital level, we have, or the clinician level, we have very good medicines, we have good diagnostics. We have good diagnostics, etc. At the community level, we may be able to detect the patients with TB, etc. But to ensure that they continue with the treatment and complete their treatment and do not default and they are followed up, etc. For that, there is a program. And usually when we talk about program, we are talking about multiple stakeholders who are involved in that program. And then we will find implementation problems. And that is where we need to use the health system lens to understand why a particular program is not working the way it should be working. And then, of course, to plan interventions in the future, for the future. I'll just take an example from each of this. So usually when we tackle a problem, okay, let's say pediatric TB diagnosis is poor, we look at level 1, which is what we see, what is happening, what the data tells us. But we rarely go below that. What is this? Why is this been happening over time? Our national TB program is more than 50 years old, the original one. Since then, pediatric TB has not been diagnosed, effectively. So what is the pattern? Why is it that doctors and the health services are not able to diagnose? What are the structures which are continuing with this patterns? What are the mental models which support and keep this pattern problem in place? So the basic essential thing what I'm talking about is when you are using the health systems lens, you go deeper into the problem, trying to understand why this problem exists. Not just at the problem level, but try to look at the patterns, the structures, the people who are involved, because at every stage, the people are involved. I tried to come up with an example. Oops, sorry. I don't know why this is. I tried to come up with an example of TB, but I've not worked much in TB. So I decided not to, go to a more place where I'm comfortable. This is a study which we did in one other state in South India, where the government asked us to help them tackle this problem of cesarean section rate. So they said there's a very high cesarean section rate. It's all these private sector people, they are very greedy, they want to make money, etc. So we went there, we looked at the data, and we found, yes, private sector cesarean rates were very high, but 1/3 of the cesarean rates were happening in government facilities. So government facilities, it was not low in government facilities. So then the hypothesis that it is because of the greed of the obstetrician kind of did not match. That could be one reason, but there may be other reasons. So we said, okay, let's look at it. We talked to the doctors, obstetricians in the government facilities, and we found that what is this? Sorry. Yeah. They were saying that the main problem is overcrowding at, I'm sorry, I don't know, this thing is doing its own thing. So overcrowding at district, can you see this thing? What's that? My cursor?
Yes, we can.
Yeah. So they started off saying it's overcrowding at the district hospitals. That is why. And so the nurses do not have the competence, because the nurses are put there on fortnightly, roster. So every 2 weeks, a nurse from the labor room is shifted to the OP, and then from there to the surgical ward, and then to the medical ward, etc., and then finally comes 6 months later back to the labor room. So they have forgotten their competence of managing deliveries and identifying high risks, etc. And so when the obstetricians are faced with 10 to 20 pregnant women in distress, in delivery, they find the cesarean section much easier to do, because otherwise monitoring a pregnant woman is very time consuming and very difficult. Of course, there was the added issues of most of them have a very flourishing private practice, and so they prefer to go to their private practice after 4 p.m. This particular district hospital is also recognized for medical college teaching. So the OBG PGs used to come and say, please let us do cesareans. So that is one more incentive. Then, of course, the informant. So this is the standard narrative, which we all thought, yeah, possible. This is the. But when we started digging a little more, we found that this overcrowding is actually contributed by a policy. That particular government has said that no deliveries should happen at the PHC. Everything should be happening at the CHC level and Taluk hospital level, not at the PHC, because the MBBS doctors cannot provide safe delivery services. So people had to bypass this, and then they went to the CHC. But at the CHC, there is usually one obstetrician and one anesthetist, but they are on alternate day duty. So the night that the obstetrician is on duty, the anesthetist is not on duty. The night the anesthetist is on duty, the obstetrician is not on duty. So there's a total mismatch of these two key individuals. So you can't do cesarean sections after 4 p.m. till next day, 8 a.m. Of course, the specialists were also not too keen. They said, oh, there's a lot of violence against doctors. People come shout, break the furniture, etc. So we don't want to take any risk. So we prefer to send people straight to the district hospital. Okay. So we said that is one thing. If we can tackle this and we can maybe tackle this, maybe this will be reduced a little. Then we came across another issue that this particular government had a free ambulance service which would take pregnant women from point A to point B, no questions asked. We are not talking 108, a special separate ambulance service for only pregnant women. So they could just call up and say, listen, I am getting labor pains, take me to some hospital. and the ambulance will come and pick them up. And then the third policy issue was about all the pregnant women who delivered in an institution, especially a government institution, received free birthing kit, a very nice kit with blanket, sheets, clothes for the baby, some powder, etc. And most mothers like to have it, but that is only available at the district hospital.
It's 5 o'clock.
So what happens is that here you've got a free ambulance service. Here the government is nudging you to go to the district hospital, and then the women want to deliver want to have a cesarean section because they have been told by their society, by their mothers, their grandmothers, their aunts, etc. You are very weak and frail. You cannot take the labor pains. So it is better to do a cesarean section. That will hurt you only for 1 hour. But if you are going into normal labor, it will hurt for 8 hours and you will be in terrible thing. You do not have the strength. So the pregnant women themselves have been brainwashed both by the society as well as by the ashas and the doctors, etc., that cesarean is better than normal vaginal delivery. So now you see this, if we have to tackle this problem, we have to work at all these levels. So it is just not about working at health services and increasing the capacity of the doctors and obstetricians. We have to work at the community. We have to look at the policy. We have to look at the governance. We have to look at the way financial incentives are provided or not provided, etc. So this is how we look at a problem from a health systems lens and say, there's no point in just creating more doctors here or building the capacity of the nurses. We also need to, if we want to make a change in this, we have to also work at all these levels. So this is, then how do you plan an intervention? I'm just showing you a small 3-minute video from a WHO experience. It's quite, can you hear the?
Yes, Dr. Bendas.
Okay, fine.
In the 1950s, the Dayak people of Borneo, an island in Southeast Asia, were suffering from an outbreak of malaria. So they called the World Health Organization for help. The World Health Organization had a ready-made solution, which was to spray copious amounts of DDT around the island. With the application of DDT, the mosquitoes that carried the malaria were knocked down, and so was the malaria. There were some interesting side effects, though. The first was that the roofs of people's houses began to collapse on their heads. Turns out the DDT not only killed off the malaria-carrying mosquitoes, but it also killed a species of parasitic wasp that had controlled a population of thatch-eating caterpillars. Thatch being what the roofs of the Dayak people's homes were made from. Without the wasps, the caterpillars multiplied and flourished and began munching their way through the villagers' roofs. That was just the beginning. The DDT affected a lot of the island's other insects, which were eaten by the resident population of small lizards called geckos. The biological half-life of DDT is around 8 years, so animals like geckos do not metabolize it very fast. It stays in their system for a long time. Over time, the geckos began to accumulate pretty high levels of DDT, and while they tolerated the DDT fairly well, the island's resident cats, which dined on the geckos, did not. The cats ate the geckos, and the DDT contained in the geckos killed the cats. With the cats gone, the island's population of rats came out to play. We all know what happens when rats multiply and flourish. Pretty soon the Dayak people were back on the phone to the World Health Organization, only this time it wasn't malaria that was the problem. It was the plague and the destruction of their grain stores, both of which were caused by the overpopulation of rats. This time, though, the World Health Organization didn't have a ready-made solution and had to invent one. What did they do? They decided to parachute live cats into Borneo. Operation Cat Drop occurred courtesy of the Royal Air Force and eventually stabilized the situation.
So that is when we are planning, we tend to look at the immediate outputs. But when we are talking of a systemic thinking, systems thinking, we need to realize that everything around us is a system. Wherever we intervene has ripple effects, and because it is connected to something else. And so when we are planning or when we are analyzing programs, we need to look beyond the obvious, try and see the larger picture, try and see the connections. Then only we can come up with sustainable solutions which will hopefully be effective. So, thank you very much. And yeah, I'll stop here.
Thank you, Dr. Devadasan, for that nice presentation. And it's wonderful to have that WHO video shared. It's very thought-provoking. And you have really established why we need a systems lens. I do not have a question. We will open up for the floor, but I have a comment. Currently, what WHO believes is not only in the health systems approach for TB, it believes that we need other systems also to hold hand with the TB health systems. That's why WHO has come up with a multi-sectoral accountability framework for TB that narrates about the national level, multiple sectors, the industry departments, the home departments, and other similar ministries and departments coming up, also with the private sector and the non-governmental sector, and also with the community. That needs that kind of a partnership and a bigger system approach rather than a health system approach alone. But it is easier said than done. The implementing a bigger systems approach is very, very difficult. But let us hope that that kind of an approach would help us faster addressing the TB issue. So I will open up this floor for one or two questions quickly. I don't see a question in the chat. Do we have a hand raised, Swati?
No, sir, we don't have.
In the Q&A box also, I don't see any question.
Yeah.
So thank you, Professor Devadasan. We will move on to the next session.
Thank you very much, and pleasure meeting you and the rest of the team. Thank you very much.
Thanks.
Thank you.
So our next session is about some field experiences. This is experience from the field working with children with TB in India. So this session is going to be presented by Dr. Satish Kumar, who is the country head of SATI, and a medical doctor cum public health professional with 2 decades of work experience in designing and managing diverse health projects in pediatric TB, STI and HIV prevention, treatment, HIV self-testing, LGBTIQ+ health, private health sector engagement, decentralizing HIV and TB care, health system strengthening, and adolescent health. He has co-led a few research projects, including implementation research on private sector pediatric TB, operational research on TB and COVID, and impact evaluation of the HIV continuum of care. With that kind of a vast experience in the field, Dr. Satish, I know, will be able to guide us through how pediatric TB is to be tackled with the system approach, because he is a system scientist also. So welcome, Dr. Satish, on board.
Good evening, Dr. Shibu, and good evening, all of you. Am I audible, sir?
Yes, you are very much.
Yeah. And is the screen visible, sir?
Yes, your screen is.
Okay. Yeah. Thank you. And first, I would like to thank the organizers here who have given this opportunity to share about the pediatric TB project experiences. And I think it's it's indeed a great pleasure that, we are with interacting with good group of researchers and the youngsters here to talk about pediatric TB aspects, because we have a huge potential on pediatric TB research, which we heard in the last 2 days. So I would like to share the 2 project experiences here, which Sati as a public health organization, we had opportunity to work closely, collaboratively, work with the TB and TEP program with all the stakeholders. So I would like to share 2 project experiences. The first one is Catalyzing Pediatric TB Innovations, CAPTB project, which is actually the focus of the project is working with private health sector on pediatric TB. So the project was implemented between 2018 to 21, funded by United in close collaboration with and also ECPAF, Elizabeth Glaser Pediatric AIDS Foundation, is a prime recipient in 9 African countries, and in India we are a subgrantee to ECPAF in doing the private sector pediatric TB. The project goal is to contribute to reduction in morbidity and mortality due to pediatric TB over 3 years, 2018 to 21. The project was implemented. You can see the project implemented in 15 districts across 3 states. That means 5 districts across each of these states, Maharashtra, Andhra, Telangana. The project was implemented in private health sector. The models, we can see that there are 2 models you can see. The one is evidence generation sites, where we work with 82 facilities. The second one is the district-wide technical support to the TB program, where we work with the larger private pediatric practitioners, covering as much of the private pediatric practitioners as possible. And this these 2 models, when we worked out, it was done in collaboration with professional medical associations of IAP, IMA, Pulmonologist and ENT Doctors Association. This project was implemented. So these are, so I will explain these 2 models in this private sector engagement process for pediatric. Yeah. So the first model is about evidence generation. So this project, we had 2 years of experience between 2019 to 21, where we had 82 sites where we partnered with. It's a tripartite MOU signed between the government, the individual district TB officer, and Sati, and the private pediatric sites as a kind of implementation research site, where we started with 6 districts and then we gradually increased to 9 and 15 districts over the next year. And we established 57 sites from the beginning of the year 1, and then we increased to 82 study sites. So the entire experience around how the partnership with the 82 private pediatric sites and the data was collected and how implementation experience, I would like to share it here. So we can see how this project started with experience of private sector engagement. We started doing first mapping of private health facilities and identified private health facilities who are providing pediatric services. So almost out of 6,559 mapped facilities, 3,000 plus were identified to be pediatric service providers. Almost like an average, you can say 200 pediatric providers per district. And among them, we were able to access 2,600 facilities and identified around 192 private pediatric sites who are high load. High load means primarily around 800 to 1,000 pediatric OPD, willing to do sample collection and comprehensive pediatric TB management. And among them, we signed an MOU with around 6 sites per district. So almost we reached 82 sites. So this is one example of how the sites were distributed in Ahmednagar in Maharashtra district, where you can see the district has 309 pediatric sites across 14 talukas plus municipal corporation. And we had almost 14 sites in this district. Sorry, we have actually 14 sites distributed across 7 talukas from municipal corporation, which has like 8 rural and 6 urban sites in this district. Because this district is very huge, we had a higher representation in this Ahmednagar district. So that way we wanted to have the spread of the sites across the district. So the activities involved in these 82 sites are: first activity is intensified case finding through systematic screening of every child who is coming to the OPD and also IPD. If the child is identified as presumptive TB, then the child is offered free chest X-ray and sample collection, for which the financial support is given by through this project and for sample collection and chest X-ray. So patient don't need to pay for services, and also an expert radiologist who interprets the chest X-ray. At the time of this implementation, and even now, artificial intelligence for chest X-ray reading is not validated by WHO and approved by WHO and the TB program. So hence we had expert radiologists, and if any samples are collected, they were tested at NAT centers for which a sample transportation agent collected the sample, transported the sample to the government CVNAT and TrueNAT centers where free CVNAT testing was done. And if anybody found to be TB positive, then started on treatment. If TB negative, then the follow-up ends there. In reality, we followed up the TB negative individuals also to understand, whether there is any problem or not. But primarily, our intervention was focused more on TB positives, and then further, following up with them for treatment and contact tracing visits. So this is the entire cascade of services provided for a child visiting the private sector 82 sites. So this is the intensified case finding format, where you can see that we have actually trained the doctors and the paramedic staff. The paramedic staff are given incentives on a monthly basis so that they can screen every child who's coming to the OPD without missing any child. They were screened, so they were given incentives also, and the incentives also helped in ensuring close to 80 to 99% of the presumptive TB had chest X-ray also on the same day, and so the incentive helped a lot in that way. So we can see the ICF form. The left side white color one and the right side gray color one. So every child who's coming to the OPD were screened for the symptoms by the paramedic staff, who will mark any child with any of the symptoms which is non-specific symptoms. Cough means yes, she ticks marks, and then if any child is tick marked on the left side, the child goes with the form to the doctor, and the doctor looks at the now specific symptoms: cough more than 2 weeks, wheeze more than 2 weeks, fever more than 10 days. So there is a specific symptom based on the WHO guidelines. So this was designed across 10 countries. Actually, this was standard. This format was in standard format. So this is how the screening happened. So if any child is found to be right side positive, yes, any child is found to be yes, then the child is identified as presumptive TB, and further evaluation starts from there. Towards this intervention, we designed this pediatric TB treatment chart and TB screening poster, and also supported the national TB program in conducting national TOT. These 3 states where this project is implemented, 3 state TOTs, and in all 15 districts, we supported the district level trainings on pediatric TB guidelines, so that all the private health facilities in these 15 districts, we could reach out and then give these IEC materials, and also the pediatricians are trained in that way. So that's the technical intervention we did there. So this is the key summary findings. We had almost 11,68,760 attendees, OPD and IPD attendees in this pediatric 82 sites, out of which 72 were screened, not 100% screened, 72% were screened, and 63% had some form of symptom. The left side form, white color form, found to be 63% symptomatic. But then when they went to the doctor, the right side form found declared presumptive TB is 3,499, which is 0.4% of the screened one. And the number of TB positives identified is 0.04% of those screened, or 11% of the presumptive TB turned out to be positive detection. And in this cascade, 84% had X-ray done, 50% of the presumptive TB cases had samples collected and evaluated with NAT, and 96% of those identified as TB positives were initiated on treatment, with majority started on public FTCs. So the number needed to screen to identify a presumptive TB child is 240, and number needed to screen to identify a TB positive child is 2,129. So it's so we can see if a pediatric OPD hospital is having 1,000 OPD, then there is a higher probability that they may identify one TB positive child over 2 to 3 months period. So that's one live connection to how this is related to program. And this is about the NAT testing results. So we can see the lymph node aspirate and lymph node biopsy had a highest yield of 33% from biopsy, and 13% from lymph node aspirate has a higher positivity rate of NAT testing, whereas the other expected sputum induced sputum had around 3 to 5%, gastric aspirate, all these are 3 to 5% positivity. So on an average altogether, among all those samples tested with NAT, we had 5% NAT positivity. Majority of the TB cases identified through this study was less than 6 years. We can actually connect this to correlate with Dr. Mattu sir's presentation, where he showed the gap is very high among younger age children. So this we had good experience in this, where we found majority of the cases, that is 51% of the children identified are actually less than 6 years, and then another 29% 6 to 10 years, and 20% were 11 to 14 years. So this also correlates with one more point, that majority of the children, younger age group, goes to pediatricians, whereas older children, they go to other practitioners also. So, so we had more pediatric TB at younger age group identified because of engagement of pediatrician. We had similar proportion of males and females, and 80% of them were actually clinically diagnosed, and 20% of the identified were microbiologically diagnosed cases. Among those identified, we had 89% of the 99% had initiated on treatment. With the government FDCs, actually, we the almost like more than 85% of them had started on the government FDCs, and 89% of those started on treatment completed. We had 5% lost to follow-up and treatment stopped, and 5% death rate. We can see treatment stopped. Our experience was around 1 to 2%. I think it was around somewhere 1 to 2%. Rest were lost to follow-up. So these are the images of the government FDCs, which are dispersible flavored ones, strawberry, raspberry flavored ones, which are available in the program. The private practitioners had a very good acceptance rate of the government FDCs, and they referred the children for the government FDCs. This actually also increased the acceptance among the families also, with a better completion rate. So we can see that the private practitioners actually prescribed more of the public FDCs. It increased from 79% when we started the project. 79% of them prescribed public FDCs. It increased to almost 89% of them prescribed public FDCs. This actually case study was also published in the WHO operational handbook. The reason this case study got published is that you can see the private FDCs combination 50, 75, 150 HRZ combination is the public FDC, whereas private FDC combinations is 50, 100, 300 HRZ, and another FDC 75, 150, 400, another FDC which is only HR is 100 milligram. So the combinations gives an unstandardized doses. It is difficult to use, and we have advocated with this with these findings with the private pediatricians with the IAP chapters, and they have taken up the prescription of public FDCs after those advocacies. And so the better acceptance rate happened in the private FDC. So we felt that advocating with the IAP and the private providers and linking up with government FDCs improved the uptake of FDCs, and hence this was published as a case study. So I have completed the experience sharing of the first model, which is working with 82 public sites, 82 private sites. Now I will move to the next experience, where in the 15 districts, where we try to follow up with all the private pediatric sites through district-wide technical support. Almost through these 15 districts, coverage of 15 districts, all pediatricians, we covered almost like 3,000 plus private pediatric providers, and we identified 2,225 TB cases over 2 to 2.5 years. This entire project happened during the peak of 2 COVID years, so our numbers may be relatively lesser than anticipated. But however, we had a rich experience of this 15 districts coverage. So I'll explain a little bit more experience about how the district-wide coverage happened. So when we were doing this project, we found during COVID period, very limited number of cases we were getting it during COVID lockdowns. So at the time, we got permission to analyze the data of 2017 to 20 of 15 districts and try to understand where are these children going, TB positive children going, and where are they getting reported. So you can see that the data shows of the age disaggregated data of 0 to 5 years, 6 to 10 years, and 11 to 14 years data, where you can see that in 0 to 5 years, pediatric TB cases identified, 75% of them were identified by pediatricians, and then very limited numbers were identified by other practitioners, like chest physicians, general physicians. But as age increases, the more number of cases were identified by pediatricians, and you can see 35% are identified by pediatricians among 7 to 14 years age group. So we realized this analysis helped us to target not only pediatricians to increase the pediatric TB cases in the district. We have to cover chest physicians, general physicians, even ENT doctors, because they get a lot of lymph node swellings, and other practitioners, general practitioners, so that we can reach as many pediatric TB cases. So we want to see in the first phase 6 districts, what happened in those 6 districts, whether the progress happened. So we are presenting how around average of we covered 3,000 private providers, pediatricians, and we can see in 2019, 271 pediatricians report at least one presumptive TB case, and 160 pediatric practitioners report at least one TB positive. It increased in 2020 to 325 to 48, and in 2021 a little decline happened. But in both the years, we know the COVID was major barrier, in covering as many people. But at least throughout the course of the project period, we had almost 563 facilities reported at least one presumptive TB, and 431 facilities reported at least one TB cases. I would like to state one case study of a Karimnagar district where we try to saturate as many private pediatric practitioners. You can see in Karimnagar in 2017, the pediatric TB notification rate was 1%. It increased to 3% over 2019 and 20. So through saturating all the 153 pediatric facilities in the district, we almost had 48 out of them reported at least one pediatric TB case. So through a saturation of coverage approach, we had actually reached from 1% to 3%. Nevertheless, 3% is not a good number. It needs to be increased to 10%. But during the period of COVID, this happened. With the saturation, the increase happened. So we learned that if in our country, in a district, if pediatric TB cases in private sector has to be increased, then we can go with two models or two kind of approach in a district, where we can have a selective model of pediatric hub sites with the pediatricians, and also who is partnered with pathologists and radiologists as a hub site, so that we can have a comprehensive pediatric TB services provided by these hub sites, and also saturate all the other pediatric practitioners and establish their linkages with these hub sites. Through this approach, we can reach as many pediatric TB cases as per the estimated numbers in a district. So this is one great learning we had in this project, and we have shared these learnings with the private PPSA current agencies who are implementing the private sector engagement in the country through various meetings and conferences organized by the TB program, and we are advocating to scale up these models across the country. And so the learnings from our side is that engaging pediatricians is essential for filling the gap in pediatric TB case finding, especially 0 to 5 years. Engaging high-load pediatric sites as hub sites is very essential to provide comprehensive pediatric TB services, and engaging different type of providers is essential to saturate pediatric TB coverage. And then further, if we partner with IAP for active engagement, the way Dr. Rakesh nicely explained the STEPS model, we can have collaborative with all the PM professional medical associations and IAP especially, where we can have one IAP nodal person in each district and state identified who can recommend the sites and who can actually participate in the review meetings at the district level and contribute to really saturating the coverage in the district. So this is our critical learning for saturating the coverage in private sector. And through this project, actually, we have done the National Policy Assessment on Pediatric TB, which was actually published by CTD also. And CTD has made a lot of efforts in improving pediatric TB over a period of time. Dr. Mattu sir has explained all the initiatives. And CTD has also published the collaborative framework for integrating TB with RBSK, RKSK programs. And this project experience has been presented in the best practice documentation by CTD on creating synergies to ensure quality TB care. And the WHO operational handbook published the public sector FDCs prescribed by the private practitioners, and the policy brief which we have submitted on how intensified case finding can increase the pediatric TB detection in private sector. So these are some of the experiences from this project has been used to advocate or for policy changes. We worked on this. So now I'll switch from first project to the second project, which is decentralizing pediatric TB care services in both public and private health sector. This project is implemented over a 1 year period. It recently got completed between 22 to 23, funded by USAID and JSI in partnership with the NTP project across 5 districts. This is implemented. I will share primarily the experience of public health sector because the private health sector experiences largely remains the same in this project also. So I will focus more on public health sector. This project was built with the focus of this integrating pediatric TB with the health system. So with this model, this project was designed and implemented, wherein the children with vulnerabilities, malnourished children, symptomatic children, contact trace history, children with contact history and unresolved pneumonia in the community could be identified at various entry points. Whenever they come for these entry points, they can be screened, which includes public sector, secondary and tertiary health facilities, during community health outreach activities, during child health programmatic activities of RBSK, RKSK, when they visit to the schools also, across the private health sector, and child nutrition programs of Anganwadi and NRCs, and contact tracing activities. So through these activities, we plan to see that children can be screened at these entry points. But largely our proposal was mostly focusing on the public sector secondary health facility, because the project is about decentralizing TB care. But we also thought that the other entry points could be touched upon wherever possible. So if any child is identified as presumptive TB from these entry points, they would be referred to these secondary facilities or tertiary facilities, where they would be evaluated and further they will be diagnosed and treated. So I will explain further details in the next slide. The focus of this project, as I mentioned, is the secondary level care facilities, which is the elliptical circle which is shown. So what we wanted to do is at the community level, you can see the referrals from PHC and health and wellness centers, referrals from A&M, ASHAs, Anganwadi workers, referrals from contact tracing, and people who are directly walking. So these were the group which we wanted to target. So that way they will be referring the presumptive TB cases to the secondary level care facilities. That is CHC, sub-district hospitals and district hospitals, where every child has to be screened and presumptive TB has to be identified. And after identification, they will be taken X-ray, and the X-ray will be interpreted by an expert, so that immediately the child is having abnormal X-ray, then samples can be collected and the samples to be transmitted to NAT. And any complex cases are there, then they would be referred to medical colleges for tertiary care management. The focus is as at the secondary level. So what we did is, you can all the red colored ones during situational analysis we found are the gap areas. That means we need to build referrals. We need to build a presumptive TB identification through capacity building of the sub-district facility doctors, which is primarily pediatricians and medical officers. Majority of the secondary level facilities do not have pediatricians. So the medical officers have to be trained on pediatric TB diagnostic algorithm, so that they will identify presumptive TB. And the X-ray is taken immediately, but X-rays are not available in the sub-district facility. So we built in partnership with the labs, neighborhood X-ray diagnostic center, so that X-rays are taken immediately on the same day. And then we provided consumables and equipments to those facilities for sample collection, primarily gastric aspirate and induced sputum sample collection procedures. And we also planned on-site mentorship visits by the experts from the medical colleges, so that on-site doctors and nurses or capacities are built for sample collection, and sample also transported immediately to the NAT centers in that way. And but we found that a lot of places at sub-district facilities, microscopy was still used, so we advocated for NAT testing. And then lastly, the medical colleges were the most important technical unit in this project, where they provided district level capacity building training activities, and they were the mentors also, and they were also the experts in chest X-ray interpretation and also handling extrapulmonary TB cases. So this way, the model was built in these 5 districts. To give a glimpse of these 5 districts in UP, Maharashtra, Telangana, Assam, Chhattisgarh, each of these 5 states had 1 district selected. We can see in these 5 districts, 4 districts had medical colleges, 6 district headquarters hospitals, out of which we selected 3 as hub sites in this project. Community health centers, CHCs, have 65 facilities, out of which 29 were selected. Private pediatric sites, we had 291 sites, and which 18 were selected as hub sites. But largely, I'm going to explain on the public sector activities here. And in addition, we can see the 252 health and wellness centers at PHC level, and 2,450 health and wellness centers at sub-centers are available in these districts. So the hub sites were decided in consultation with the DTO, and for private sector, additionally with the IAP leadership. So the first activity we did is, we did a master trainers training in these 5 districts, and we had 35 master trainers trained, who in turn trained the 95 site staff, which includes 27 medical officers and 77 staff nurses at a common district level training held at primarily medical college level. And then at the on-site level, like like Dr. Devadasan sir said, all the nurses are not trained, all the medical officers are not trained. So what we did is, we did an on-site training also at these facilities, and almost 833 hub site staff were trained on-site by the mentor pediatricians. And also they did hands-on support for the sample collection using mannequin or real-time support in various site visits during mentorship. Through this process, in addition, we also sensitized at the community level almost 3,693 community members, sensitized over a period of 3 to 4 months, involving ASHAs, ANMs, CHOs, Anganwadi workers, RBSK MOs, and PHC MOs. They referred 84 presumptive TB cases, Out of them, 6 turned out to be positive. So the demand generation with the community happened through these frontline workers sensitization, who were also referring cases in that way. Because this project was 1 year, the actual results were only for 6 to 8 months. We can see the results of this project. In these 50 sites, 16 had in-house test facilities, in-house test X-ray facilities, but we partnered with 26 test X-ray labs in every place so that on the same day X-ray can be done. And when the analysis of facility assessment, none of the sites had this 6 and 8 small size gastric aspirate Ryle's tube available. So we provided these Ryle's tube to the facilities across all the places. Similarly, nebulization machines and consumables needed for nebulizer were provided. Primarily, hypertonic saline was not available. Access to chest X-ray interpretations. We had 14 sites had pediatricians and rest of the sites did not have pediatricians. So the linkages were established with an expert, a pediatrician and radiologist. And NAT testing, we had 15 out of 32 sites in the public sector had NAT machines, and the private sector did not have NAT machines. So all the sites were linked to CBNAT and TrueNAT machines. So the cascade data is, the result is that we had 1,044 presumed TB cases identified, out of which 71% had been evaluated with chest X-ray. And then 39% of those X-ray tested had abnormal chest X-ray. And among those abnormal chest X-rays, 91% had samples collected at these sub-district facilities, which includes gastric aspirate induced sputum, FNAC, and expectorated sputum. All these samples were collected, and 7% of the presumptive TB cases were found to be positive. 82% of the samples collected were tested under NAT. Still 18% we can see that they were tested with microscopy, because the microscopy, it's a behavior change of switching from microscopy to NAT. And one important thing is 77% of those identified TB cases were microbiologically diagnosed because of NAT testing. So this was one of the important positive factor that the gastric aspirate induced sputum were done at sub-district facilities, and majority were tested with NAT and majority were diagnosed with microbiological diagnosis. So this is a trend of how X-rays, when we started the project, X-ray evaluation was limited and then it increased. And then we can see the number of hubs conducting sample collection procedures. At baseline, 12 sites reported doing gastric aspirate, increased to 41 sites. And at baseline, 9 sites doing induced sputum, increased to 22 sites. One of the important things is that we found majority of the doctors, nurses preferred more to do gastric aspirate than induced sputum in the initial days, and hence there was it took some time to make the changes in the induced sputum, and that's why more change happened in gastric aspirate than induced sputum. But now we are seeing a better pattern with induced sputum also. Gastric aspirate is done for 0 to 6, and induced sputum is preferably done for 6 to 10 years old child. So we wanted to understand the outcome here. So before and after intervention, so we actually compared the data of the 1 year before the intervention and during intervention. So in these 5 districts, 689 cases were notified. Actually, this is not pediatric TB. There is a mistake there. District notifications were 689 and 915. District pediatric TB notification increased. What the number came from these sites actually is that 69 cases came from these sites before intervention, and it doubled to 140 cases from these sites. So so we can see 69 out of 689 pediatric TB notifications, 10% of them came before the intervention from these sites. It increased to 15%. So these sites, the number of pediatric TB cases reduction doubled, and the contribution to the district pediatric TB notification increased from 10% to 15% over a period of 6 to 7 months of active field level intervention in these sites. There were a lot of advocacy happened for these, making changes to integrate pediatric TB services with various RBSK services, WCD services, and other departments, so that they would be able to screen and identify and refer. So these are some of the outcomes. So few key learnings we want to share is that to bring in some of the behavior micro changes, we have introduced a stamp model. Like you saw in the private sector, we had a ICF slip. So we tried to introduce a small stamp model in each of these hub sites and government sites, so that whenever a child is identified as a presumptive TB, they will put a seal and then tick mark which symptom they identified as a presumptive TB and send it to the X-ray center. So when the X-ray center, the child goes with this seal one, the X-ray technician understands this child is a presumptive TB and immediately takes the X-ray. This also helps the nurse to give an attention to counsel the parent as a presumptive TB and ensure that the child is investigated immediately. And we had a WhatsApp group where the doctors posted the X-rays to the experts, and the experts immediately gave feedback, which helped in identifying the abnormalities on an immediate basis. And hands-on training for sample collection help to improve the nurses, especially nurses, to have a behavior change. They need to get a confidence. Actually, we had a nurse mentor also introduced in 2 places who actually helped in improving the skills part of it. And engaging medical colleges helped in actually throughout the district activities. As an expert, they helped in the program services. And we also did a patient feedback survey. I have just few more slides. I'll complete fast. We did a patient feedback survey in 2 rounds. So this data is the second round data with 69 parents and caregivers of the children, pediatric TB, including presumptive TB and TB positive children we interviewed. 37% of them reported visiting 1 to 5 facilities before they visited the hub sites, and the expenses incurred out of pocket was around 950 rupees. 88% of them, after identified as presumptive TB, had chest X-ray, and in that, because of the partnership with X-ray sites, even though public sector did not have X-ray center, they immediately took the X-ray in the partnership centers, and they did not get any. They did not pay for any money. 21% paid for chest X-ray, but actually. In Chhattisgarh, in Amravati, in few places, the government hospitals, you need to pay 25 rupees or 50 rupees for X-ray. So that money paid for chest X-ray is actually within the government facility. Due to the government norms, they paid. So having partnership with X-ray helped to reduce the cost or no cost for the patient for chest X-ray on the same day. And among the 11 TB positives we interviewed, actually 8 had taken public FDCs and 8 are taking public treatment, 3 is taken from private hospitals. In that, 9 are taking public FDCs and 2 are from private FDCs. The cost of the private FDC drug is 600 rupees per month. This information we identified late, and then now we are fixing the private FDC issues with all these patients. And all of them were started treatment within 2 days of diagnosis, and majority of them were followed by the NTP staff through phone or home visits. You can also see the age distribution of this study when we had representation from all the age groups of the TB positive parents. Gastric aspirate, 19 parents we interviewed. They reported, 2 of them reported doing gastric aspirate on the same day when they visited as presumptive TB. They were done same day. 13 were done next day, and 4 people were done 3rd day or later. It is helpful that one of the important learning from here is educating parents by the doctors and nurses on the importance of sample collection procedures is essential for acceptance of these procedures, especially at sub-district level. The doctors, nurses have educated them, and because of that, almost like 15 people got GA procedure on the same day or next day. And we can see GA procedures were conducted by the nurse in 9 cases, and out of another 10 cases, both nurse and doctor did the procedures, and 5 out of 19 reported doing overnight admission. When it comes to induced sputum, same day was done in 4 cases among 11. Next day done 5, and 2 cases were done a little later. And induced sputum was done by nurse or nurse and doctor together. And you can see induced sputum are done among various age groups of 1 5-year-old child, 10 from 6 to 10 age group, even older children of 7 children of 11 to 14 age group, and 9 children from 15 to 18 were done also expectorate sputum. So the nurses supported by the doctors gave them confidence to do these procedures. And one of the important issues we found is that the expectorated sputum is also collected from less than 10 years old children, and we have to address those expectorated sputum also in this part of it. So we can see expectorated sputum is there for a 5-year-old child and 6 to 10 years old child, and that has to be addressed. So the last few slides, the challenges are there with
Satish, sorry for interrupting. Is it the last slide or last few slides? I would expect you to finish it.
Last slide, yes. I'll go with this last slide. So what are the scope for research is we have, we found that there are in the operational implementation research, there is a scope for doing, using stool samples, when it gets implemented in the field, there is a scope for doing acceptance and the real implementation challenges study. And newer tools getting introduced now in the program for using handheld chest X-ray device and telehealth being used, and process evaluations on pediatric TB program can be done. And pediatric TB surveillance can be, also institutionalized through various projects and research studies. TPT, including role of nutrition among the specific group of children, and TPT acceptance adherence can be studied. And also the adolescent TB who got positive TB and then cohort follow for infertility could be studied. So these are some of the areas we learned from these project experience that research could be done. And these are some of the materials developed to sensitize the frontline workers, SOPs for sample collection procedures, and medical officers guidebook. These are some draft stage. It is yet to be approved by CTD, and we are in the process of approval. So that's the last slide. Thank you. I sorry it took a little bit more time, but thank you for all.
Okay, thank you, Dr. Satish. That was a very good presentation, complementing many of the presentations by our previous speakers. This is a systems approach, example for systems approach to early systems approach. So I would just ask one question, though it's not a part of your studies. We have diagnosed pediatric TB, but have we done any kind of a reverse contact tracing to identify the index TB cases in their households?
Yes, in these projects, reverse contact tracing is being done. It is happening, but our case detection was very less. Very few cases were identified. So yeah, so hence that complete details I didn't present here.
True. Very good. So, Satish, you have really invited some questions from our participants. I'll just read through the questions in the QA box.
Yeah, please.
The first question is about any comment on the sustainability of the model without incentives to the staff.
In our in the NTP program, we all know there is an informant incentive is there for private sector also. And the private sector providers also getting incentives. So we can motivate the private providers using the informant incentive model for private sector currently under the TB program. And then also we can motivate the doctors to if they are willing to share the incentives, the notification money 500 rupees they get to be shared with their with the upside with their own paramedical staff. That would play a role of motivation. We are seeing a lot of private providers not accepting the not willing to take up the notification money. They are actually opting out of that. Instead of opting out, they can actually take that money as an incentive and give it to their paramedical staff. That way, this would be sustainable in that way.
Okay. So that means that incentive is very helpful in sustaining this activity. That is what you are coming at. Okay, the next question is on hands-on training to the clinicians on sample collection. I think you have explained that there has been a training in the second intervention. You have mentioned about the sample collection training, right? Who followed up till the treatment completion? Is it the private hospital alone or the program staff?
The program staff. The
program staff
followed it. Yeah, the hospital people were not incentivized or given additional staff for that. So hence the program staff did that. And from a sustainability integration point of view, only the TB program staff we followed up here.
I also remember here that the program amendment on the notification order also speaks about the public health action, that is the treatment adherence support and the remaining public health action by the general health system, including the program staff. So that is a partnership. Next question is then, was there any engagement with the informal providers? I think you have spoken about the engagement with the formal providers, right? No informal providers. Yeah.
Yeah.
So
with informal providers, actually, few of our team members tried it in some of the districts like Ahmednagar and in other places in Telangana, Karimnagar and Nalgonda, those places. We tried reaching out to informal providers and we interacted with them also. We did a situational study. We found that majority of the children, maximum they go, older children, they go for the first visit and majority goes to pediatricians or formal providers. The informal providers visits we found very less. And so we focus more on formal providers. And also one more thing, we actually had only one staff in a district, and that one staff covering all the 200 formal providers itself was a challenging one, and especially this happened during COVID days. So we did have challenges with informal providers. However, we cannot rule out informal providers role, because in tribal areas, in some other areas, we found the role of informal providers are there very much, but we were not able to give that level of engagement process to this project.
Right. One more question is here. Any cost-effective study on these models?
No, cost-effectiveness study is not done on this. Yeah, it's only model building we have done. We did cost-effectiveness. Yeah.
Thank you so much, Satish. So some answers are also coming in the chat box. So please go through these, and then we will stop it there. Thank you, Satish, for that excellent presentation.
Thank you.
Yeah, so we will now try to conclude this. Dr. Pranati, are you available?
She has told that she will log off for another.
Fine. True. Thank you so much. So now we will try to conclude this. We had an excellent session. The great panelists have really gone through their topics and enriched us with new insights, new information that really help us to think through and probably move ahead in programmatic planning and the research planning and the research to policy. Dr. Mattu has been very elaborate on what the program is doing to have all the pediatric TB identified, diagnosed, treated successfully, so that the pediatric TB burden could be faster brought down. I mean, pediatric TB burden in the terms of the pediatric TB mortality. To bring down the pediatric TB the incidence, probably you have to work on the adult TB. Then Dr. Mattu also was speaking about the collaboration with other systems, the other health programs and other systems beyond the health system to have the pediatric TB addressed in the right way. Dr. Rakesh walked us through the private sector engagements and certain concepts on the private sector and how some models of private sector engagement like STEPS have really helped in engaging the private providers and taking it forward to continue the engagement of the private hospitals and the hospital management in providing the treatment care or the TB care cascade without any cascade loss. And he has very rightly told us that there is no public mycobacterial tuberculosis and private mycobacterial tuberculosis. TB is there for all. So the TB program is there for all. So it's mandatory that we have partnerships with the private sector and all the remaining sectors. The TB of pediatric TB tackled very. And he has also told us about the standards for TB care in India. I think all of us are aware about the standards of TB care. First version of the standards of TB care are available. And I remember when that has been published in 2012, and many of the private providers have been trained on the standards for TB care in India. A publication came from Mukund Dudlekar from Mumbai. And the original paper was on the practice of the clinicians in Mumbai, how they approach TB and what are the types of prescriptions they have. And probably 80 clinicians had 110 different kinds of prescriptions. And after the STCA has been published, and Indian Medical Association and many of the program managers have taken efforts to engage the private sector providers and to train them on STCA. After 10 years, Mukund again published a paper called Nothing Changed After 10 years. So that's about standards for TB care. But now with PPIA and PPSA, probably the standards of TB care is being implemented, not trained, being implemented to improve the quality of TB diagnosis and management. I wanted to ask a question to Dr. Pranati about how the PPSA model ensures the quality of TB care in the private sector. Do we have any KPIs, any key performance indicators for the quality of TB care in the private sector that has anyway been improved or otherwise due to PPSA? Then we have a discussion. Dr. Pranati has very clearly gave us how the PPSA has taken forward the agenda of the private sector engagement in the context of pediatric TB also. Dr. Devadasan was kind enough to walk us through the philosophy of the systems approach and why the systems approach is very important. That lens, beyond the public health lens, is very important for identifying or what we call the diagnosis of the problem, and then to act upon. And that system approach probably is coming up, is becoming more popular among the policymakers and the implementers. Probably that would take us forward in having the right kind of a result in our fight against tuberculosis, including the pediatric tuberculosis. Dr. Satish, thank you for those experience sharing. Probably Satish was really helping us understanding in a better way or in a practical way what the previous speakers are speaking about, how certain things can be done in a systems approach, how pediatricians or the other practitioners could be engaged to have a very focused fight, very effective fight, and very sustained fight against TB, including pediatric TB. So all these panelists have done justice to their topics. And now probably the remaining 4 to 5 minutes, I will try to just give some insights on what we are doing here, and especially on our approach to pediatric TB. So far I was speaking about pediatric TB. You know, the term pediatric TB, it doesn't paint, the term pediatric TB doesn't paint the right picture. It's a technical term. It paints a technical picture. It's probably it more highlights a clinical picture, but it doesn't project the face of an ailing child. I won't call this pediatric TB. I would call it as our children affected with TB. It speaks about the children ailing with TB, but we should not forget the fact that the children affected by TB are manifold than the children ailing with TB. You know what proportion, what number of TB, what number of children are losing their livelihood, losing their parents, losing their dreams because of their parents' TB. They are thrown away to the labor camps. They are thrown away to the streets. So pediatric TB doesn't end with a coughing child or a sick-looking child. It is much beyond that. So TB among children is beyond what it seems to be from outside. The TB among children is a direct indicator of the endemic and epidemiologic transmission. When I say direct indicator of the endemic, I should tell you that if there is a child affected by TB, there are hundreds of adults with TB, and the problem of TB is not being tackled at all. The programs do fail in addressing the issue of TB. So a receding epidemic probably will have fast coming down incidence of pediatric TB because the pediatric infections are coming down. Then breaking down to active TB disease is coming down. And because of that, we are very sure that the actual transmission and the transmission pressure and adult TB is actually coming in. You know, the UN high-level meeting that has held in 2018, that has made the countries, the member states, to commit to put 3.5 million children with TB on treatment. But we just managed to achieve 54% at the end of 2020. The commitment by the member states to end for the MDR TB was 115,000, 1,15,000. But we achieved only 15% by the end of 2021. The WHO estimates for the TB under 14 years in India for the year 2021 was 356,000, 3,56,000. But what the program has notified is 120,000, that is 1.2 lakhs. That's what Dr. Mattu was alluding to. However, we were not reviewing the global program here. We are not reviewing the country program or the state program. We were in a group of researchers, young researchers. So let us ask some questions to our. You know, while we address the issue of TB of our children, the approach usually revolves around the clinical shortcomings. We speak about lack of specialists, We speak about lack of diagnostics. We speak about lack of hospital settings to admit them, to manage. Often difficulty to collect biological specimen and complexity in diagnosis is blamed as culprits. Is it so? Or are these the problems what are the roadblocks to diagnosing and managing pediatric TB? I think there are much beyond that. And that's what you have to find out. You have to find answers to these questions. So is the gap in reporting due to missing of diagnosis or missing of reporting? What does the pediatric TB drug sales tell us? Is it coming down? Or can we estimate what is the absolute number of children who could be treated with those pediatric TB drugs? And are we notifying that much? If there is a pediatric drug sale, that means that is diagnosed. Only the diagnosed pediatric TB or the diagnosed children will consume those drugs that is who are sold by the chemist. So are we missing diagnosis or are we missing reporting? What type of clinicians provide TB care? What type of clinicians do provide TB care to the children in India? Are all of them the specialists? Are all of them based at the hospital? Satish told us that it's not always the pediatricians. There's the general practitioners, the other specialists, and even people outside the qualified, the umbrella, qualified providers umbrella. Are the home-based specialists and general practitioners also providing TB care? If so, how to engage them? It is not only the hospital-based engagement approaches could help us. Approximately 60% of the eligible child contacts under 5 years have received INH preventive therapy, despite the availability of isoniazid acid all across the country. Adolescent household contacts, that prophylaxis to the adolescent household contacts is yet to take shape. So what prevents our country from achieving universal coverage for TB preventive treatment for children? Is it myths about the preventive TB treatment? Is the no-do gap? Or is it the shortage of resources? We know undernutrition is a key determinant of TB in India, especially the TB of children. Do the preventive and therapeutic nutritional management reach the beneficiaries at the right time? Many children have been provided with preventive therapy in the past, maybe 10 to 12 years, under 5 years of age. What happened to them? Did any of them break down into active TB? Or did we really protect them? So there are a number of questions there out for the researchers to answer. So this has been, I hope, a good opportunity for all of us to think through, introspect, and to look for data and information within the program, outside the program, and from the community, and those ailing children. Let us go to them, ask them, find solutions. So I encourage you to do intense research for policy and to prevent the tears from our children's eyes. With that, we conclude this session. And back to you, Swati.
Thank you so much, sir. What a wonderful way to summarize it. The day's wonderful sessions. Thank you so much. May I request all the panelists to switch on their cameras so that we can have a virtual group photo? Yes, ready? Okay, done. Thank you so much. So It has been wonderful 2 days of science meeting on pediatric TB, and all the speakers and the chairpersons whom we had are super hectic scheduled people, and they took out their time to converse with us young scientists and the faculty as well, and spend such a lot of quality time with us in this regard. So to propose a formal vote of thanks as we conclude the 2-day-long science meeting on pediatric TB, we are left with a lot of insights from some of the greatest minds in the country on things to work on. It has indeed been a pleasure being a part of this venture. I thank PRERNA Group for providing such an opportunity for us young scientists to converse and share ideas with the experts, contextualizing on pediatric TB. Big thank you to all the eminent panelists and chairpersons who took time out of their busy schedules to nurture us youngsters. Gratitude to all the former and current young investigators, YIs, and other members from CMC Vellore, CHRD SAS, and KEM-HRC for being a part of this. Special thanks to Dilesh and Dr. Aritra for being part of the organizing committee. Heartfelt thank you to my colleagues here at KEM-HRC and the IT support team, office team for helping us with the organization and all other kinds of support. Last but not the least, thank you to the audience who joined us for the webinar from India and abroad, interacted with us, and made it a success. Thank you so much.
Thank you. Great job, Swati.
Thank you so much, ma'am.
Bye.
Thank you. Bye.
Bye. Thank you. Bye.
Bye all.